Welcome to the 301st session of the Right Care Initiative. We've had our first public meeting in 2008, and we are so grateful to our volunteer leaders and our supporters from academia, from government, from health systems, and from the biopharmaceutical industry. This session is being recorded. The slides and video will be posted on our website within 48 hours. Hopefully by tonight, we'll be sending out an email that sends you those links if you want to review anything. If you have substantive content questions, please use the Q&A tab at the bottom center of your screen. Operations questions should be emailed to Albert Yeam, albert1030@berkeley.edu. Next slide, please. I want to dedicate this meeting to our military and our national security professionals, such as my mother, who died at the age of 54 of a stroke, who motivates my work greatly. I want to point out this wonderful slide that Steve Sidney from Kaiser sent me, showing that by the age of 45, already 1 in 20 women have evidence of coronary calcium, and 1 in 7 men. Next slide, please. Dr. Ed Yu from Palo Alto Medical Foundation is our co-chair of the Right Care Initiative, and I would like to skip forward for a moment while he's able to join by sound. Please go to the agenda.
Hi, Heidi.
Oh, good. Okay, Ed, I'll hand it to you in just a moment. So I'm going to very briefly say that our agenda has 3 parts to it. We will be going through the state of the evidence for an hour and a half. We'll have a 5-minute bio break. We will have a 1-hour debate, and then we will have a panel discussion, including Q&A. So please use the Q&A feature if you have questions. And let's go back to the last slide. I'll just say welcome, Dr. Ed Yu. I'm going to hand the meeting over to you. Dr. Ed Yu is the Vice President and Chief Quality Officer of the very well-known, high-performing Palo Alto Medical Foundation. And with that, Ed, thanks for joining us and talking with us about this important context for our half-day meeting on coronary artery calcium.
Thank you, Hattie, and well, thank you all for joining us. It's a pleasure to be here. What you see on the slide here is a database from the CDC called the Wonder Database, and what you're seeing here are death rates calculated based on death certificate information across the United States. And to set the context for our meeting over here, the data you see is broken down in red for women and in blue and in men, and along 3 different age bands. And to echo what Hattie has mentioned earlier, I draw your attention to the youngest age band, ages 35 to 44. And in the second column, the third column to the left, you see that ischemic heart disease is listed as the cause of death for these populations at these rates. Naturally, the older you are, the higher the incidence of these. But the thing that jumps out at you that for women ages 35 to 44, 5.5 out of 100,000 case deaths are caused by ischemic heart disease based on death certificate information. And if you drop on the bottom in the blue section, for men, it's much higher at 16.1 out of 100K. Now, to put that in further context, we're here in this Right Care Initiative to reduce deaths from strokes and heart attack. And what you see highlighted in beige over there are the total death rates, the total cause of deaths combining hypertension, ischemic heart disease, and strokes all together. And as you can see from those numbers, for the youngest age band, for women, almost half of them are from ischemic heart disease. And for men, over 50% of the deaths in those age bands are from ischemic heart disease. And that sets the tone and sets the stage for a question here, just that given where we are right now, from a preventative standpoint, is there something else that we could do or we can look at to catch these patients who are dying from these at these younger ages from these conditions? There's more that we could do that we can consider to bring into practice to help identify these patients early and avoid these potentially preventable deaths. So on that note, I would like to then introduce my fellow co-chair, Dr. Joseph Skye, who is also one of the co-chair of the Right Care Initiative, to kick off our discussion. He's a great person to be here because he currently serves as the Chief of Preventive Cardiology for the Grant David U.S. Air Force Medical Center, serving our veterans, active duty military personnel and their families. In addition, he has also served as a flight medicine physician and then the Chief of Internal Medicine for the Air Force School of Aerospace Medicine. He's very interested in integrating modern medical therapy approaches and using evidence-based preventive medicine to allow military pilots and their professionals to continue flying even if they have cardiovascular diseases. And on top of it, I want to give recognition and credit for Dr. Skye's service. He has returned from a tour duty from Afghanistan in 2018. And he's very excited to continue his clinical practice in a state and time where the science shows the proven value of complementary preventive cardiology. I can think of no better person to kick us off. And Dr. Skye, I'm going to turn the table to you to continue our agenda. Thank you very much.
Thank you so much, Ed, for that wonderful introduction. And today, in the interest of time, I'll keep moving quickly. So I want to introduce the subject of coronary calcium by talking about high-risk occupational medical standards, specifically that of flyers. Next slide, please. These views are my own and don't represent the Air Force, the Department of Defense, or the government. Next slide. Jenny, you can just keep them moving. I'll keep up with you. So this story starts in 1963 when President Kennedy dedicated the U.S. Air Force School of Aerospace Medicine. And this was part of Congress's plans, along with the Kennedy administration, to fund to put a man on the moon. And the resources dedicated to the School of Aerospace Medicine were set up to develop new medical standards for pilots, and from the pilot corps in the military were to come the astronauts. And so President Kennedy, when he justified to the American people the spending of a tremendous amount of money at the time to achieve the best in human performance, he said his vision was that all humans would benefit from it, that the average person would also benefit when we learned about the best of human performance. And so when I think of the space program, I think of not just Velcro or Tang, I think of coronary calcium and aerobics, as you'll learn in a few minutes. So after a few years of working on medical standards for military aviators and the space program, a new challenge was presented to the School of Aerospace Medicine. An article came out that showed that the older pilots in the commercial aviation field, because at that time, most pilots in the commercial aviation came from military pilots as they retired and left, were dying at an unsafe rate, primarily from cardiovascular disease, and that there was this need for reliable, high-yield predictors of heart disease. Next slide. And I should have mentioned that the Kennedy administration and Congress, when they funded the program at Brooks City Base to develop new medical standards, they made the doctors and the medical researchers that worked in that program not work for other doctors, but they worked for the scientists and the engineers that were developing the space program. And that resulted in one key feature in that they now had to work under new rules. They had to work under the rules that the engineers used to make flying safer. And so this story is best illustrated with the comedic piece put in the British Medical Journal a few years ago that, of course, we use parachutes, yet, of course, they've never been studied in randomized controlled trials. Next slide. However, when the medical standards for pilots were being developed, there was a specific guidance that we couldn't do prospective research that randomized things because these were our best and brightest people. We couldn't dare subject them to things that would unnecessarily disqualify people. So we were limited in that all research had to basically be occupational registries with retrospective analysis to learn what was safe. Next slide, please. And yet this turned out to be a benefit because this is the way that aviation had become safer. And I'll illustrate this. The first time I was able to see this illustrated was a few years ago. I became the flight surgeon for the 418th Flight Test Squadron. And in fact, we had a parachute team that tested parachutes and developed some of the safest parachutes in the world. Of course, not through randomized controlled trials, but through meticulous attention to registries of all parachutes produced, new tests that were unblinded to look for better innovations, and then tracking those innovations as they were deployed into the field. Next slide. This type of science, or high reliability science, is used throughout the aviation community and in other fields where randomized controlled trials are just simply not possible. Next slide. I think the success that the aerospace medicine industry has had is remarkable. Starting in the 1950s, there were about 40 deaths per million flight hours. And using the concepts of high reliability science, we're now at a point where the most recent data shows death rates of about 0.4% per million flight hours. Next slide. Just a quick example, in 2016, when Southwest Airlines had its first fatal mishap where a single person died from an exploding fan blade, within weeks, the registries that already existed within the Federal Aviation Administration and the European Aviation Safety Administration, they had data on 30,000 engines that contain these type of fan blades, 800 million flight hours from 500 different airlines, not only the dates and types of ways that they were produced, but also the ways they've been inspected. And they were able to retrospectively go back, look at that, and develop a tighter inspection schedule to prevent these mishaps. And I would argue that had we tried to solve this problem through randomized controlled trials, we would probably just now be getting the data on what to do to make that a safer engine. Next slide. So in this sense, the physicians and medical researchers were challenged by the engineers that led the safety innovations to make the humans as safe as the machines had come. And this is a very large topic that has entire chapters and textbooks, but I'll very quickly cover it. Even in the healthiest, youngest pilots, cardiovascular mortality still happens in about 1 in 10 and 9, or an annual rate of about 1 in 100,000. So to this day, whenever you get on a commercial airline flight, there are always 2 pilots, because that level of safety, to be as safe as the machines themselves, is not achievable with 1 pilot. And even with 2 pilots, there needs to be an incapacitation rate of around 1 in 10 to the 6th, or an annual rate of about 1%. Next slide. The US Air Force School of Aerospace Medicine had already been collecting flight physicals and exam data on every pilot since the beginning of Army aviation, and then the Army Air Corps, or the Army Air Corps, and then the US Air Force. And yet in the 1970s, as a result of this effort to develop better screening protocols, there were an expansion of the tests done to include coronary angiography on about 1,500 aviators, and then meticulous tracking and analysis of this registry. Next slide. Within about 10 years, it became clear that, as expected with Bayesian statistics, no test performs well when the disease prevalence is low, especially in a very young, healthy population. So given this fact, the test that performed the best turned out to be coronary calcium scoring. Initially, this was done with just plain old fluoroscopy. However, over time, it transitioned to coronary calcium scoring using scored CTs. Next slide. And over time, this allowed for screening of pilots. And then, of course, as most people know, NASA astronauts come out of military pilots. And this has been done successfully now for several years, as I'll show in a few minutes, achieving that 1% rule. And in a few minutes, Dr. Harrell will introduce the current state of this research as how it has been applied to other members of the military, but certainly in the Air Force, without formal policy, it is certainly commonplace for flight surgeons to screen other high-risk individuals, such as special operators, that need to be at their best performance, not only for themselves, but also for the success of the mission. Next slide. I mentioned that aerobics also came out of the space program. Some of you may know Dr. Ken Cooper was a flight surgeon in the Air Force at the School of Aerospace Medicine. And he noticed that the astronaut candidates and the pilots that were the most aerobic also were the most likely to maintain their fitness and to continue to pass their flight physicals. And so to this day, we all know the concepts of aerobics by his developing an aerobics program and including it as a key feature of high performance medicine for our aviators. Next slide. So in summary, coronary calcium has been at the key to identifying risk and making aviation safer, both for the military as well as the civilian aviation community, as it wouldn't come as a surprise to most people that most of the staff at the Federal Aviation Administration were former military flight docs, both primarily in the Army and the Navy. And this has been a wonderful success story, as I'll show in a second. Next slide. In 1915, at the end of the First World War, analysis showed that of military aircraft accidents, about 50% were related to medical conditions. Then as time progressed, these inflection points are not exact, they're just meant to represent the concepts. As basic physicals improved, most medical problems were excluded. However, as I've already mentioned, by the 1970s, cardiac disease became the real challenge, was to identify cardiovascular risk. But using coronary calcium screening as the primary tool, in addition to the standard tools, the success rates have now been well under the 1%. Next slide, please. With the current state for the US Air Force of about 0.5% for the risk of a cardiac event in an active duty pilot. Next slide. So I think this picture to me illustrates two things. For Chuck Yeager, in his lifetime, we saw that the practice of high reliability science without randomized controlled trials led to a remarkable improvement in the safety of airplanes and the speed of airplanes. And then for those of us that were lucky enough to work with tremendous engineers and pilots like this, in my lifetime, we've seen the screening tools to reliably keep our military pilots safe, and for that matter, commercial airlines safe, evolve to the point now where we can easily achieve these goals. Next slide. And now I would like to introduce Dr. Harrell. Dr. Harrell is a commander in the United States Navy, and he is currently the chief of cardiology at the Walter Reed National Military Medical Center. Most importantly, though, he is an expert in preventive cardiology. He has been on the writing committee for the VA and DoD clinical practice guidelines for hypertension, both in the 2014 and the 2020 releases. And this is where I first met Dr. Harrell, was working with him on the 2020 guidelines. It's been a joy to know him, and I think we will learn today as he will. Oh, I also forgot to mention he's an associate professor of medicine at the military's School of Medicine. But today we're going to learn how his ongoing study, for which he's an investigator, the Aging Warrior Study, is expanding the use of coronary calcium to serve the needs of screening for cardiovascular disease in the military. Dr. Harrell, we're looking forward to your presentation.
Great. Thank you, Dr. Sky. I really appreciate the kind introduction. And it's certainly my honor to talk a little bit about coronary artery calcification and coronary disease in our military populations and military health system. Next, please. Also just a general disclaimer from the Department of Defense that these are my views and opinions and not those of the Department of Defense or Department of the Navy or US government. So I'm going to generally review a little bit of coronary artery disease and its association with sudden cardiac death in the U.S. military. Talk a little bit about the prevalence of calcific or calcified coronary artery atherosclerosis in our military populations, the relations of coronary artery calcium or CAC, its associated risk on future coronary heart events, and the use of statins and incidence of cardiovascular events as defined by their CAC status. Next, please. So cardiovascular screening in the military, as Dr. Sky alluded to, has been a longstanding occupational risk evaluation within the military. Starting in 1981, the U.S. Army developed the Cardiovascular Screening Program, which was later revised in the late 80s, with the goal to reduce the incidence of sudden cardiac death associated with its semi-annual Army fitness test. Each branch of service has their own physical fitness test, and it is associated with a small but non-negligible risk of sudden cardiac death. The U.S. Army developed a program to try to reduce the risk of this. This was through routine health screenings as part of their periodic physical exams and in a health risk appraisal tool. And they mandated screening for individuals who are at high risk and age 40 or older, or for which is the older age for our active duty population, but maybe sort of early middle age for the general population. High risk status was defined as a Framingham risk index of 7.5% or greater, which is a 6-year risk of clinical coronary artery disease, a total cholesterol at HDL ratio greater than 6, and a combined presence of total cholesterol greater than 240, hypertension, and tobacco use. And then it was left up to the individual physicians taking care of these patients for how best to further evaluate them. But often during this period, an exercise stress test was performed. And then if the patient or the personnel passed it, then they would be able to go on to take their physical fitness test. Next, please. So despite this, though, over a 20-year period after the introduction, there was no significant change in the incidence of sudden cardiac death in middle-aged soldiers. So due to this, there was a movement to try to find new tools to help better risk stratify our military population. Next, please. This is this is an autopsy study on all members of the U.S. military over a 10-year period who had sudden cardiac death. And what I want to point out in this slide is that if you look at our age categories across the bottom, starting between age 20 through age 34, those dark bars and light gray bars are the incidence of sudden cardiac death in men and women. And then starting at age 35, you see that dark bar climb exponentially. If you look at the white bars on the far right for each column, that's sort of the prevalence of coronary artery disease or atherosclerotic coronary artery disease. And you notice that it marches upward in the same sort of trajectory as sudden cardiac death. And that's because the majority of these cases of sudden cardiac death in the military are due to underlying coronary artery disease. Next, please. If you look at the age breakdown of under 35 versus over 35, you can see that atherosclerotic disease, as defined by on autopsy, recent MI, prior myocardial infarction, or obstructive coronary artery disease on autopsy. It was the most common cause in both age groups. As you can see in the age greater than 35 or older, it was nearly 3/4 of these patients who had sudden cardiac death. It was due to underlying coronary artery disease. Next, please. And so just to kind of highlight again, I want to really highlight that age 35 and up is where coronary artery disease starts increasing in prevalence, and sudden cardiac death increases at a very similar rate. Next, please. If you look at the group of patients who had atherosclerotic coronary artery disease or coronary atherosclerosis as their cause for death, which was overall a little bit more than 50% of the total group, on average, they were age 43, but about 1 in 8 were under the age of 35. Given it's a military population, it's overwhelmingly male, especially during this period, but 98% male. If you look at their medical history, they were a relatively healthy group, which, as you would expect for a military population with low rates of obesity and diabetes, About 1 in 4 had hypertension, and about 1 in 3 had hyperlipidemia based on their prior conditions noted. If you look at their cholesterol screening, of which a minority of them actually had done, but of those who did have it performed, they really had only mild hyperlipidemia with a total cholesterol of 215 on average with an LDL of 137. So using risk factors alone did not help really delineate those patients who would have sudden cardiac death due to coronary artery disease. Next, please. And if you looked at their medical records, only a little over half had any prior symptoms that could be referable to cardiovascular disease, meaning that for these patients who had sudden cardiac death, their first signs or symptoms of coronary heart disease was a cardiac arrest. Due to this, we had to find better tools to better risk evaluate our patients so they don't present with their first symptoms of cardiovascular disease being a cardiac arrest. Next, please. Due to this background, there was congressionally directed medical research to help find new tools to better risk stratify our populations, which led to the Prospective Army Coronary Calcium Study, which had multiple arms to it, but the main arm was looking at those active duty Army in the National Capital Region who were age 40 to 49, and enrolling them prospectively to assess whether or not electron beam CT or coronary artery calcium scoring would be able to risk stratify these patients over time. It was expected to have up to 2,000 patients self-referred for this. And the goal was to get as many as we could. Next, please. As part of this, Walter Reed Army Medical Center, which you can see here on the right, over on Georgia Avenue, was expanding its cardiac CT practice, looking at all comers, so not just active duty. They reported their first 3,200 patients who they were screened for coronary artery calcium from August of 97 to February 1999. Now, if you look at their male population, it was overwhelmingly male population, most of whom were either active duty or retired military. For women, it was about 24% were active duty or retired military. Most were dependents having not served in the military. Next, please. This is sort of an unselected population for all comers. And you can look in the younger age groups of 20 to 39. As you expect, most patients have no coronary artery calcium there, 84%. But surprisingly, even at that young age group, there is 15% of this non-selected population had coronary artery calcium, with 3% being in the high CAC group, which is a score greater than 400. Next, please. If we focus in on this group of patients who we start with these older active duty, this 40 to 49 and 50 to 59, you can see that there's fairly high rates of coronary artery calcification in this group, with nearly 40% of these patients in the 40 to 49 group having coronary artery calcium, and over half in the 50 to 59 group, with respected increases across each category as patients get older. Next, please. If you look at the active duty component for the study, this is sort of their first report, initial report of their first 630 patients who were enrolled. Again, because it's an active duty military study, it's overwhelmingly male at 82%. On average, these patients were 42 years of age, white and college educated. If you look at their cardiovascular risk factors, they're really reasonably healthy. Again, similar to prior reports with the sudden cardiac death population, where about 1 in 4 had hypertension, pretty low rates of tobacco use and diabetes, and about a quarter having a family history of coronary artery disease. Most of these patients did not have coronary artery calcium, with a median calcium score of 0. And a very low risk population, if you look at their 5-year Framingham Risk Index, was only 1.6%. If you break it down by gender, though, and you look at the presence of coronary artery calcium, approximately 20% of the men had coronary artery calcification, and fairly low rates of women of only 4%. Next, please. I want to focus here on this bar graph where this is broken down by quartiles for that 5-year predicted coronary heart disease risk index. But if you look at this risk index and see which patients were going to have coronary artery calcium, you can see that it was a very poor risk predictor. Approximately almost 40% of the patients who would be in this low risk category had coronary artery calcium. So it's the risk score alone did not really delineate on who was going to have CAC. Next, please. This is the same cohort. This is all their risk factors listed on the left regarding their presence of coronary artery calcium or having no coronary artery calcium. Good. Next, please, we're going to look at a zoomed in view of those risk factors that were statistically significant. But I think if you look closely, each category, there's really a minimal difference in BMI, total cholesterol, blood pressure, or even the risk index between those patients who had calcium and those patients who did not have calcium in their coronary arteries. There's a very mild difference in the LDL level and total cholesterol levels, but clinically, this would not really help, I think, delineate who's going to have coronary artery calcium. Next, please. And if you look on the chart on the right and sort of looking at LDL versus 5-year risk index as part of risk stratifier to see who was going to have calcium, it was they were both very poor on delineating who was going to have coronary artery calcium. It shows you that just looking at risk factors alone or risk score doesn't help you as much as one would hope. Next, please. If you look at the 3-year follow-up of the study, this is including all 2,000 subjects that were enrolled. And again, similar age, 43, 81% male. And if you look at the men and women, the women generally were a lower risk cohort than the men. 10-year risk, Framingham risk index for coronary heart disease for men, the overall population was only 5%, which is pretty low risk group. If you look at the calcium score, the median calcium score for men was 0, again, meaning that over half of them had no coronary artery atherosclerosis. But the mean score was about 20. And if you look at it broken down into the different bins of CAC score 1 to 9 or minimal, calcium score of 10 to 44, which is sort of a low, mild group, and then a calcium score of 45 or greater, which is in the mid-range for mild, but this incorporates moderate and heavy coronary artery atherosclerosis. Each of those groups were roughly equal. But I think the big takeaway from this is if you look at those patients who had no coronary artery calcium, they were at a very low risk for coronary heart disease events over this, on average, 3-year follow-up period. If those patients who had any coronary artery atherosclerosis, they had an 11-fold increased risk for coronary heart disease events over this 3-year period. Next, please. This is the 5-year follow-up, but you can see very similar curves here. And so these results persist out to, on average, 5 years or up to 8 years of follow-up. Those patients who had no coronary artery atherosclerosis based on their calcium score were at very low risk for events, and any coronary atherosclerosis was associated with a higher risk of coronary heart disease events. If you look at the patients who had coronary heart disease events versus no event, there was a very small difference in the Framingham risk score, 4.5% for no events versus 6.5% if they did. So it was not a great delineator of future risk of coronary heart disease events. Those patients who did have a coronary heart disease event, on average, their calcium score was 146, which is moderate coronary artery calcification, versus a mean score of only 17 for those who did not have an event. The rates of coronary artery atherosclerosis were much higher in those patients who had coronary artery disease events, with 63% of those patients having CAC on CT scan. Next slide. I'd like to introduce a more recent study that was initiated in 2019 that we call the Aging Warrior Study. This is a multi-center prospective cohort study of asymptomatic active duty subjects who are generally at low to intermediate risk for atherosclerotic cardiovascular disease events. This was started at the Naval Medical Center in San Diego and is expanding to Naval Medical Center Portsmouth and Walter Reed here, with a planned enrollment of 1,000 subjects over 4 years, with up to 10 years for clinical follow-up for events. Next, please. This is sort of our initial report that we presented at the American College of Cardiology meeting in 2021 with our first 100 patients. We've actually enrolled over 200 patients now. On average, our age is 47, so it's a slightly older cohort than the PAC study. Higher rates of risk factors in this cohort, with the majority having hyperlipidemia, almost half having history of hypertension, still about a quarter with family history of coronary heart disease, and low rates of tobacco and diabetes. So low risk cohort, 10-year ASCVD risk based on the pooled cohort equation of 3.9%, so under 5%, a low risk cohort. If you look at our CAC data from this, 44% of these patients have had a positive CAC score, meaning that they have coronary artery atherosclerosis. And you can look at the bins on the right for these columns. So about 20% of the patients have a minimal or very low risk score, and 14% had mild calcification. But then we had, about 5% of patients had moderate and 4% had severe or heavy coronary artery atherosclerosis. And again, this is a low risk cohort. So this is, pretty high rates of coronary artery calcification that we're seeing in our military population. Next, please. If you look at the Walter Reed Coronary Artery Calcium Registry from our data here, you look at coronary artery calcium. This is looking at myocardial infarction on the top left, stroke on the top right, total cardiovascular events and mortality in the bottom left, and total mortality in the bottom right. Each of these risk curves represents coronary artery calcium at different levels. So the solid line at the bottom is a calcium score of 0, followed by mild, moderate, and heavy coronary calcium, respectively, for each of these lines. And you can see at each level of calcium, there's an increased risk profile for cardiovascular events, which include high stroke and mortality. So the higher your coronary artery calcium, it's associated with a higher rate of events and mortality. Next, please. I think that the really interesting thing from this registry is they looked at the risk of events with background statin use. And if you look at the bottom red line, so this is, a calcium score of 0 with a dashed line over top of it. So regardless of whether or not you were on a statin, event rate was the same and it was pretty low. But if you had any calcium, so a calcium score greater than 0, the solid blue line is if you were on a statin, and the dashed blue line is if you were not on a statin. So statin use or background statin use was associated with a lower rate of events if you had a positive calcium score. Next, please. If you look, this is sort of the same data, but broken down with different calcium score levels. So the top left is that calcium score 0, where the lines are overlapped completely. Even with mild coronary artery calcium, so a score of 1 to 100, you see there's already a separation of the curves. As your calcium score gets higher into the moderate and heavy calcification ranges, there's a pretty wide divide between if you have a statin, you're in that bottom red dashed line, versus if you were not on a statin, you have a much higher rate of events. So this is an association from a registry study, not a randomized controlled trial, but I think that there's calcium scores certainly showing that you're increased risk for cardiovascular events, and that if you're on background statin therapy, it's associated with a lower rate of events over time if you do have coronary artery calcification. Next, please. So reviews, coronary artery disease is the #1 cause of sudden cardiac death in our U.S. military personnel. Calcified coronary atherosclerosis is highly prevalent generally in asymptomatic middle-aged military personnel. We know that CAC is associated with the risk of future coronary heart events, as well as stroke and cardiovascular death. And I think there's really good registry data showing that the use of statins is associated with a lower rate of cardiovascular events in those patients who do have coronary artery calcification. Next, please. These are my reference that I used. Next, please. So thank you for the opportunity to talk today. I'm going to stop here, and I'm going to introduce our next speaker. So this is a great opportunity for me to hand it off to Dr. Matthew Budoff, who's a professor of medicine at UCLA Harbor and the David Geffen School of Medicine. He is well known in the field of preventive cardiology, calcium scoring, as well as cardiac CTs, the director of the cardiac CT program at UCLA Harbor. He is well published and well known in this field. So I'm very much looking forward to handing off to Dr. Budoff now and hearing his presentation.
Thank you, Dr. Harrell. That was great. And I will share my screen and take oh, not that screen. Okay.
That was good.
I'm sorry, Hattie?
We're on. We've got
Great.
your right slide.
All right. So, I was asked to just do an overview of some of the data available to us with coronary calcium scoring. So I'll take you through a little bit of the data and a little bit of the current guidelines and where we are. This is my conflict of interest. So, you know, we currently have this pooled cohort equation, which unfortunately, as I'll show you, doesn't work that well in clinical practice. And I know Dr. Ron is on the call, and I'll show you some of his data that really shows that this grossly overestimates risk. And the problem with overestimating risk is that you end up with a markedly lower compliance. People who don't perceive that they are truly at risk will not stay on therapy. And one of the huge advantages of coronary calcium is it's a wonderful stimulus for better adherence. And that's built into all of the outcome studies as part of the potential benefit of doing coronary calcium, is that you're going to get better adherence. And I'll show you some data from 2 randomized trials to that effect. This is from Jamal's work. This is the 307,000 patients. In orange is the expected event rate for very low, intermediate, and high risk patients. You'll see it's a 5-year predicted risk group. So if you doubled those numbers, you would get, you know, less than 5%, 5 to 7.5, 7.5 to 10, and greater than 10. But you can see in orange what the expected rates were in this huge non-diabetic population. And then in blue are the actual event rates. And clearly, about a 5-fold overestimation by the pooled risk equation. So I think one of the biggest problems that we've seen, one of the biggest issues that we've had, is that we haven't been able to properly stratify risk, and we don't do a great job of stratifying who has obstructive disease either, but this is a real big problem. If we're going to try to match intensity of therapy to intensity of risk, we need an accurate risk assessment model. And as you heard from Dr. Sky and Dr. Harrell, coronary calcium provides us with a much more accurate model for who will have a future event, and therefore who may benefit from things like statins, and as I'll show you, aspirin. And the guidelines go beyond that. They talk about better blood pressure control and other therapies that should be added in the setting of a high calcium score. Now, coronary calcium is not the entire plaque burden. It's, as John Rumberger, one of the early pioneers of this field, always said, it's the tip of the iceberg. When you see an iceberg floating along the surface of the water, if the Titanic was going down, it saw about 20% of the risk. It didn't send divers down below the surface of the water to see if there was a larger or any ice under the surface that could rip the hull of the ship. It knew what to expect based on what it saw above the water. Same is true of coronary calcium. In general, especially in patients older than the age of 40 years old, you can see that calcified plaque, and this is based on intravascular ultrasound and histology, about 20% of total plaque burden is calcified, and about 80% is fibrotic and lipid rich. But the bigger the iceberg, the more coronary calcium you see, the more fibrotic and lipid-rich plaque exists. So it's a great surrogate for total plaque burden, again, with probably a minimum age of about 40 years old. In young people, very young people especially, you start getting a dissociation between calcified plaque and atherosclerosis, but also, probably more important, between calcified plaque and thrombosis. Probably many of our young patients who suffer of myocardial infarction or sudden cardiac death don't have typical atherosclerotic coronary disease. They probably have a thrombotic disease from high fibrinogen, from smoking, from prothrombotic factors. Even COVID has caused a number of myocardial infarctions due to a prothrombotic state, and calcium is not part of thrombosis. So a very stable pattern. This is one of the early studies. This was a population-based study called the St. Francis Heart Study, a prospective 5-year observational study in about 5,000 patients. And you can see if patients had a score of 0, they had a remarkably low event over the next 5 years. That red line at 2% represented what we used to call high risk, which was a 2% per year or 10-year risk of 20%. And you can see that scores above 100 clearly cross that line, and scores higher and ever higher in a linear fashion increase your risk of cardiovascular events. Now, this data was published in 2005, and when it was published, people said, oh, it can't be correct. It's too good to be true. It predicted events with a relative risk of 9.5-fold. Coronary events over 10-fold. And if you just look at hard cardiac events, if you had a calcium score above 100, you were 9.9 times more likely to suffer a heart attack or death. This is the same time that Paul Ritker was peddling C-reactive protein to us with a relative risk of 1.17. So this is 10-fold increased risk, whereas the biomarkers are a 1.1-fold increased risk. And thus people were skeptical that calcium could really predict events as well as it did. I then published this in 25,000 asymptomatic patients. This was just looking at all-cause mortality, but you can see with perfect discrimination, the patients who lived the next 12 years largely had a score of 0. And with each incremental increase in the burden of coronary calcium, a score going to 1 to 10 imparted a lower survival, 11 to 100, lower yet, and so on, all the way down until you see patients who had a calcium score above 1,000 had a mortality rate over the next decade of over 25%, all-cause mortality. So with perfect discrimination, and interestingly, the hazard ratio for a calcium score above 100 was 10.4-fold increased risk, almost exactly the same number that was demonstrated for cardiovascular death in the St. Francis trial. Then MESA came out, the multi-ethnic study of atherosclerosis, published by Bob Detrano at my institution in the New England Journal of Medicine in 2008. And you can see again, perfectly concordant data with a hazard ratio of 10.26 for MI and cardiac death among this follow-up period. So you can see again a 10-fold increased risk imparted by coronary calcium in different studies across different demographics and different methodology for following the cohorts. Yet still, calcium score of 0 imparts a very low risk, what we call the power of 0, making the patient a very low risk individual, and a score above 100 makes them a very high risk individual with near perfect discrimination. I published 10-year follow-up in MESA, and we saw perfectly similar data across every ethnic group. MESA stands for the multi-ethnic study of atherosclerosis. So 4 different racial and ethnic groups, including white, Chinese, Black, and Hispanic. And you can see in each of them, the black line represents a high-risk state, and the light gray line of score of 0 represents a low-risk state. So score of 0, even over 12 years, stays below a 7.5% event rate. Now our new definition of increased risk. So a calcium score of 0 imparts a low risk. And this was true in every race and ethnic group. It was true if you divided this group by men and women. And it was true if you divided this group by young and old. In black, you can see a score above 300, a very high risk events. This is hard ASCVD. So this is a very high risk population. And in gray, score above 100, also imparting a high risk population.
Your slides are not forwarding. We're still on the square one of white. Are you trying to show us the black now?
No, this is white. No, black line. Sorry about that. No, the black line. Sorry about that. The black line. Sorry about that. Yeah, no, I'm just showing one as an example. But the black line representing a score above 300, imparting a high risk group, and the gray line representing a also a high risk state. You saw this data already. I just wanted to point out that one of the presented by Dr. Harold previously, I just want to point out the stroke data. I think it's very important to recognize that stroke has as good, if not better, discrimination with coronary calcium than myocardial infarction. There are a lot of people who suggested that coronary calcium only predicts coronary events, in other words, heart attacks and cardiac death. But here you can see great discrimination among these different calcium scores, red being above 400 and 0 being portrayed as gray. And you can see great discrimination among stroke, as well as myocardial infarction, overall MACE, and all-cause mortality, as Dr. Harold already demonstrated. You'll hear a lot in the literature about the power of 0. This is just one study that we published, but there are many, many trials showing you that if you have a calcium score of 0, this is 7,000 patients with a score of 0 followed up for over 10 years. If you have a score of 0, your event rate is near 0. This is all-cause mortality, and 99.6% of patients were still alive with a score of 0. And in orange, you can see, even if you add in family history in the red line, you can see that number drops to 99.3%, but really doesn't add much incremental risk. So what about this discrimination between risk factors and coronary calcium scores, right? Really important to think about. We heard already that some risk factors don't discriminate well. We heard that from Dr. Sky at the beginning, and we've seen it in Dr. Rana's work from the 300,000 patients. But look how poorly it performs. This is from MESA. Look how poorly risk factors perform. Just take any of the colors. Let's just look at a yellow. If they have 0 risk factors, they have a very low risk state. And if you go to 1 risk factor, 2 risk factors, or even greater than or equal to 3 cardiac risk factors, the risk doesn't really go up much. That's true across any of the different CAC burdens. But now look, if you go from front to back, going from the bottom right, where it says greater than 3 risk factors, if you have a calcium score of 0, you're low risk. If you have a calcium score of 1 to 100, your risk is 4-fold higher. And if your calcium score is above 100, you're 10 times more likely to suffer a cardiovascular event. So calcium scoring has much more robust data to offer than just counting up risk factors or pooling risk factors in the pooled risk equation. Just to further demonstrate what we call the power of 0, these are all risk factors, or what we call negative risk markers. In other words, if you have these, you should be safe. For example, at the top, if you have an ApoA1 that's high, that's kind of a high HDL, you should be in good shape. Your risk is actually higher than the general population. So a high HDL does not impart a low risk state. A normal ankle brachial index, identified here as ABI, not better than the average in this trial. LP little a, less than 25%, not a low risk patient. But as you get to the bottom of the slide, no carotid plaque in green, you can see those patients are very low risk. And the lowest risk you can impart of a patient is either a calcium score of 0 or a calcium score less than or equal to 10, which imparted a very, very low 10-year risk in the multi-ethnic study of atherosclerosis. And we found nothing, and this is, you can look at genetics, you can look at a number of different markers. There is nothing that we know of today that imparts a lower risk for a patient than being told that they have a calcium score of 0 for the next 10 years. It's also the most robust way of reclassifying a patient, right? We have this problem in risk stratification. As a preventive cardiologist, it's great if I tell somebody they're low risk. That's easy. It's great for me to tell somebody they're high risk because I know what to do. But the problem is 40% of adults in the United States are intermediate risk, which means we don't know what to do. So what do you do with an intermediate risk patient? That's like saying gray zone. You're in the gray zone. I don't know what to do. Well, you can do a lot of different tests. We did this in MESA. We took intermediate risk participants, and we looked at things like flow-mediated dilation, which is endothelial function, and it did relatively nothing for net reclassification. We looked at ankle brachial index, and it did relatively nothing. We did a high sensitivity C-reactive protein, and it did a little bit of reclassifying. It reclassified almost 8% of patients. Family history was better. Carotid plaque, carotid IMT was a little better. But look at the bottom. Framingham risk score plus coronary calcium reclassified 66%. 2/3 of patients were no longer intermediate risk. They were either low risk, most of them were high risk. And now we can apply preventive therapies better by knowing what category they are truly in. This is called net reclassification because it has to be the probability of being correct in your classification to correctly reclassify a patient, and you get deducted if you incorrectly classify them. So this is how many times it was correct in classifying somebody as low risk or high risk. So what about secondary prevention? Can we use coronary calcium to assess somebody who's high enough risk to be a secondary prevention patient? So I did this study in the CONFIRM registry, a large registry, and we looked at 2,700 individuals who are asymptomatic without known coronary disease, and we compared them to 5,000 patients who were post-myocardial infarction, secondary prevention. And you can see here, the asymptomatic people in green had excellent 6-year survival. This is for cardiovascular events, MACE-free survival, not just all-cause mortality, but free from an MI, stroke, or cardiovascular death. And you can see as the score went up, the number of events went up and the event-free survival went down. But look at the purple line and the red line. The purple line is an asymptomatic population that had a calcium score above 300. It touches the red line. The red line are post-MI patients. So we can truly say, at least among this observational study with over 8,000 patients, that secondary prevention is achieved. You are at high risk, secondary risk equivalents are achieved when your calcium score is above 300. And you have a similar risk to those patients with myocardial infarction. So this needs further validation. We'll be hopefully publishing this in a major journal soon. This was presented at American Heart. We'll be publishing this in a major journal soon. But this helps us understand that we can even signify people are risk equivalents, and a calcium score above 300 would equate them to secondary prevention guidelines where we can start applying other therapies. I can tell you in the county of Los Angeles, where we take care of about 10 million patients among our hospital systems, a calcium score above 300 for patients with diabetes qualifies them for things like GLP-1 receptor agonists or SGLT2s, which were largely validated for risk prevention in secondary prevention cohorts only. So we consider those patients risk equivalents and treat them as if they already had a myocardial infarction as far as treatment of risk. And you can see how these lines converge after about 5 years. So there's been a lot looking at this. This is from an analysis looking at using coronary calcium and CV risk assessment for the guidelines in the ESC and AHA prevention guidelines. This was before the 2018 guidelines. This came out in 2017, but basically they just said that quantification of coronary calcium in addition to the guidelines improves stratification between subjects at high versus low risk for coronary events. So calcium can help match intensified risk factor modification to atherosclerotic plaque burden. It can also help us avoid therapy in subjects with a low coronary atherosclerosis that have very low 10-year event rates. And I'll show you more data on that in just a moment. But one concern that a lot of people have that I think was finally put to rest last month is this concept of a score of 0 not showing us soft plaque. And therefore, maybe those patients are at increased risk of having an event. And we might be missing something by doing calcium scoring and getting a 0. So this is from a 23,500 person registry out of Denmark. They followed patients over 8 years in this registry. It's a closed healthcare system, so it has excellent follow-up. And you can see among the patients with a score of 0, these were their event rates per 1,000 patient years, so very low event rates. And if they had no plaque in brown, it was exactly the same as if they had mild non-obstructive plaque in light blue, if their score was 0. It did not impart a higher risk state. So having a little bit of soft plaque was meaningless for outcomes. And even if they had more than a 50% blockage in the coronary from a non-calcified plaque, their risk was not significantly different. It was minimally increased in this patient with an obstructive plaque. So basically proving that a score of 0 is a very low risk state, even if they have some non-calcified plaque in the coronary arteries. We've seen great risk stratification with calcium scoring. I just wanted to show you and remind you, this is 10 biomarkers pooled together in the Framingham risk study, that if you look at with biomarkers and without biomarkers, there's no difference in stratification of risk. On the left is death, on the right is major adverse cardiovascular events. And really biomarkers have generally been proven to have little value as standalone tests. Now, having said that, they have great value when added to coronary calcium. So this is a really interesting study that was done, published 2 years ago now in JACC. This is looking at calcium scores plus high sensitivity troponins. So not in the setting of a myocardial infarction, but just screening patients for who's leaking troponin, who might be having microvascular or small plaque ruptures. So in light blue is a calcium score of 0 and non-detectable high sensitivity troponin, so negative and negative. In red is a calcium score of 0 with an elevated troponin, so a slight increased risk. In gray is a positive calcium score with a negative troponin. And who's the highest risk? Those patients who have both a calcium score above 0 and a detectable high sensitivity troponin. So you can further elucidate and discriminate coronary calcium. Of all the trials I've seen to date, this appears to add the most value to a calcium score as far as further risk stratification, is a calcium score plus a highly sensitive highly sensitive troponin test. CRP adds no value to coronary calcium. I'll show you that in just a moment. I want to remind people before we forget that calcium scoring is done maybe in about 1 million people a year in the United States, maybe a little more now since the new guidelines. We don't have an exact number because a lot of it is cash pay. But this lung screening should be done about 10 million times a year for patients who are higher risk for lung cancer. And we can derive a very important piece of information by looking at coronary calcium on an existing lung scan. And this is data from Dr. Shemesh out of Israel, but this is from a US cohort, lung cancer screening population. And you can see if their score was 0, if they could not find coronary calcium on a lung scan, and it's not gated, so it's not perfect, but it's certainly not a bad test, their survival was much higher than if they had a calcium score or what they call an ordinal score of above 7. It's not exactly a calcium score, it's the amount of calcium per vessel, kind of, so you can have mild, moderate, or severe disease in each of the 4 vessels of the heart, and you add it up. So you can get 0 to 12. But if you had a higher score, even above 4, which is a little bit of calcified plaque in all 4 arteries, left main and the other 3, you would have about a 4-fold increased risk of dying. And if you had a score above 7 or higher, you would have about a 5-fold increased risk of dying over the next 6 years. Now, I mentioned that intermediate risk is a problem area for us in preventive cardiology. This is another study called the Heinz-Nixdorf recall study, a population-based study done in Germany. But you can see if they had this intermediate risk in yellow, if they get scanned, about 14% of patients, about 1 in 7, have an elevated score and therefore are deemed high risk. There's a score above 100 or above the 75th percentile. If you look at this population, intermediate risk, interestingly, 2/3 have a low score. So now think back to Dr. Rana's work where we overestimated disease by 4 to 5-fold. We can eliminate 63% of those patients and properly classify them as low risk by using a calcium score, saving us on treat all, which is the current algorithm of care. And it's not just MESA, the multi-ethnic study of atherosclerosis, or the Framingham heart study, or the recall study, as you just saw. This is the Rotterdam heart study, also showing us that we can reclassify a large number of patients by using coronary calcium in this intermediate risk population. When we add C-reactive protein, we get no benefit at all for further risk classification. And this has been captured in all of the ACC guidelines starting in 2010, chaired by Dr. Greenland, who I saw on the call, and we'll be speaking later, where C-reactive protein is not a robust risk predictor, while calcium remains a robust risk predictor. And again, just looking at a bunch of different ways of stratifying risk, the only number that stands out to the far right is a calcium score for risk prediction. This is multivariate adjusted hazard ratios for having a myocardial infarction, stroke, or death. And you can see calcium score was 6-fold predictive. The next best was a NT-proBNP at about 2.5-fold predictive. And after that, most things were nominal or not significant, including CRP. So what about motivation? We say, and at least now we say a picture is worth 1,000 words. This is a play on words from an article that Dr. Greenland wrote that said a picture is not worth 1,000 words, because we didn't show this in every paper, but this has really been able to demonstrate in a repeated fashion now that the presence of coronary calcium improves things like statin adherence. We showed weight reduction, and there are randomized trials to support this. So the Eisner randomized controlled trial showed in over 2,000 patients, if you do not have a calcium score, if you did not get a calcium score, half the patients went to no scan. They got a clinical evaluation, they got a questionnaire, they had a consultation with a nurse practitioner, or they got a scan on all of those things. So did a scan add value in a prospective randomized way? And if they didn't get a scan, they did have some improvement in their risk factors. This is 4-year follow-up. But if they had coronary calcium on the right, look at the changes. They had a 3-fold better improvement in their LDL cholesterol. They had a doubling in their lowering of their blood pressure. More of them were exercising 4 years later. We're not talking about New Year's resolution over a few months. We're talking about 4 years. They had new lipid therapy started 5 times as much. New blood pressure therapy started 3 times as much. Aspirin, 3-fold more adherence, and adherence to statins was higher, significantly higher in the calcium score group than in the no scan group. And if you're worried about cost actually goes down when you add a calcium score to the population. And the reason is because you save on procedure costs. You don't need that follow-up treadmill. You don't need that follow-up nuclear scan if they have a score of 0, which a large number of people have. And medication costs go down because you don't need to treat all. You can treat selectively, and most people are over risk classified. So when you find out they have a score of 0, you can save on statin therapy. Dr. Muhlstein out of Salt Lake is doing this study. He published this data late last year called CoreCal. This is a preliminary data set from an outcome study randomizing patients to coronary calcium. But he looked at just risk factor based recommendations, pooled risk equation, or what he calls PCE based recommendations, or coronary calcium recommendations. And a reclassification from statin to no statin was much higher with a calcium score than in the pooled risk equation. And the net reclassification for calcium was much better than just the pooled risk equation by itself. It reclassified about 20% of patients. Physicians accepted the data as well more robustly. 88% of physicians started a statin after they were told that their patient had a positive calcium score, versus 75% if they were told that their patient qualifies for statins based on the pooled risk equation. Statin adherence was higher. So just like what we saw in the Eisner study from Dr. Berman in Los Angeles, we see now statin adherence goes up. About 60% of patients were adherent to statin after their calcium score, about 40% after the pooled risk equation. And after 1 year, statin adherence remained superior. LDL levels were lower. Estimated costs were similar, or there was reduced cost in coronary calcium subjects. So depending on the analysis, there was either no cost increase or cost savings by adding a calcium score to the population. So he concluded, and this was a pilot for a large outcome study that he's doing, but this is the pilot data. He concluded that coronary calcium guidance may be more efficient, personalized, cost-effective, and motivating approach to statin initiation and maintenance in primary prevention. And again, just to get this concept down, how many people actually started a high-intensity statin among this primary prevention arm? In the pooled risk equation arm in orange on the far right, 1.6% were put on high-potency statin. Look at based on a high calcium score, 27% were on a high-intensity statin. So we definitely can stratify not only who gets a statin, but how much statin do they get based on the increase in coronary calcification. It's not a yes/no test. It's a continuous variable, and the higher the score, the higher the risk. Now, this is data where we can argue about whether or not there's enough prospective randomized trials, but the St. Francis randomized study took 1,000 patients, only 1,000 patients, and randomized them to atorvastatin 20 versus placebo, making this the smallest randomized trial of statin outcomes probably ever published. Yet they were able to show that if patients had coronary calcium above the 80th percentile and they were put on atorva 20, that their event rates went down by 30%. And in patients who had a calcium score above 400, their event rates went down by 42%. So we can see the higher the calcium score, the larger the risk reduction. This is probably, we've tried to repeat studies like this. It's typically deemed unethical now to take patients with a high calcium score and randomize them to placebo. So we probably won't see a repeat of this study. And although somewhat underpowered because it was only 1,000 patients, it showed a robust risk reduction by putting people on atorvastatin 20. Remember the Jupiter trial, which I'll show you in a moment, the Jupiter trial, looking at the same randomization almost, except instead of having a high calcium score, they had a high CRP, took 17,800 patients to show a similar difference. We saw this data from Dr. Harrell. I'm not going to repeat it except to show you the futility of treating a score of 0. This is a wonderful observational, not randomized, but observational proof that treating a patient with a score of 0 does not add clinical value. There are 2 lines here, a red line representing the event rates on those patients on a statin, and a blue line representing those patients not taking a statin. And this is 9,350 patients being followed for over 10 years. And what we see is a hazard ratio of 1.00. In other words, 0% event reduction, 0% event reduction by adding a statin to a score of 0. That is futile. The number needed to treat based on this is infinity. And you can't do a randomized trial if your power analysis says you need to enroll an infinite number of people to show a difference. That's the number that we would need to enroll in the trial, would be infinity. Now, same study, smaller cohort, but look how widely those curves separate. If your calcium score is above 100 and you're treated with a statin in red versus not treated with a statin in blue. And again, observational data, but now number needed to treat drops from infinity to 12. You treat 12 people with a statin and one of them doesn't have an MI stroke or death. And this is the military. This is a healthy population. Same thing with Jupiter. The Jupiter criteria were used to pick out people who would have qualified for a statin based on the randomized trial showing rosuvastatin lowers events in patients with high CRP and different recommendations. But if that same exact population had a score of 0, the number needed to treat is 550 people for 5 years. You have to treat 550 people with a statin for 5 years, rosuvastatin 20, a high potency statin for 5 years to prevent one event. If the calcium score is above 100, you have to treat 24 people for 5 years to prevent one event. So we can discriminate who benefits from statin therapy much better than risk factors, or in this study, much better than C-reactive protein at determining overall risk and who benefits from that risk. And this has been represented in multiple papers looking at cost effectiveness. The cost effectiveness of coronary calcium is robust due to better and more accurate targeting, in particular to statin and aspirin therapy, as well as promoting more adherence to those therapies. Again, same theme over and over again, different analyses, different models. And if you look at this population, this is from Dr. Greenland, you can see coronary calcium results in a lower cost effectiveness or cost for quality of life year than treat all. So it's cost effective. And again, this is based on different assumptions, but nice data to reinforce that concept. Super quick, I want to finish up with just 2 concepts. One, if your calcium score is going up over time, that's a bad thing, regardless of statin therapy. This is the progression, this is the risk if you are non-progressor or minimal progressor. And that includes most statin patients have mild progression of their coronary calcium score. We did a scan at baseline in MESA, a scan at 2.5 years, and then followed them for another 7.5 years for events. Look what happens. Look what happens if your calcium score is going up significantly in green. Your event rates go up a lot. In blue is rapid progression, and in red is what we call extreme progression. The calcium scores are going up very quickly by 300 points per year. And the event rates from an asymptomatic population, more than 1 in 3 people had an MI, stroke, or died over the next 7 years. 1 in 3 by progressing. So getting a second scan may not be a bad way to risk stratify. And there'll be some really great data coming out early in the next month or two, showing that this holds up in other cohorts as well. One of the last concepts I want to cover is that calcium can help us with aspirin, the great unknown right now. Should we treat a patient with aspirin or not? And there's been a few great observational studies. This is mostly work by Mike Medema and the group from Hopkins. But you can see that if they have a calcium score of 0, whether or not they're high risk in red or low risk in blue, they're more likely to have a bleed. That red line represents number needed to harm. They're more likely to have a major GI bleed than benefit. If the bar is above the red line, the number needed to treat is higher than the number needed to harm. So we're doing more harm than good. If you're low risk with a score of 0 and you put them on an aspirin, a baby aspirin, you're going to treat 2,000 people to prevent a heart attack. You're going to cause 5 major bleeds, including bleeds into the brain and elsewhere. Look at the far right. Whether you're low risk or high risk, if your calcium score is above 100, you are 5 times more likely to prevent a heart attack than cause a bleed. So I think we can sort out a lot of this questions that we have about who to treat with an aspirin by saying that if you don't have atherosclerosis, you're unlikely to benefit from being on an aspirin tablet for heart disease prevention and probably don't want to treat them. And if you have atherosclerosis, calcium score above 100 especially, whether you're low risk or high risk, the benefit outweighs the risk. So we get better risk stratification. We can match risk with intensity of therapy. 50% or more patients will have scores of 0, and statins in this population have shown no benefit, especially in that Walter Reed observational study I showed you and Dr. Harrell showed you. And we can improve compliance. And I think that's really critical. So in the 2018 guidelines for heart disease prevention, for cholesterol and for the prevention guidelines, this is our algorithm of care. If their risk is either 5 to 7.5%, so low intermediate, or 7.5 to 20%, that's intermediate. So that's a lot of patients. You engage the patient in discussion regarding net benefit of statin. If the patient is undecided or you're not sure about the clinical benefit of statins, and for me, that's in most of these patients who are intermediate risk, you're supposed to consider a calcium measurement. And if you perform a calcium score and it's 0, it's below the threshold for statin benefit, and it says to avoid or postpone drug therapy. On the right, if the calcium score is above 100 or above the 75th percentile, it's above the threshold for statin benefit, and you're supposed to recommend statin therapy. And if they're low intermediate, you're supposed to consider statin therapy. A low to intermediate score like 1 to 99. Consider statin therapy now, or postpone statin therapy and consider a repeat calcium score in 5 years. And again, this is just reiterating the same thing. If the calcium score is 0 with a 2A recommendation, it is reasonable to withhold statin therapy and reassess in 5 to 10 years. And at the bottom bullet, number 7 at the bottom, if the calcium score is 100 or higher, or in the 75th percentile for age, gender, and race, it is reasonable to initiate statin therapy. So a very simple, it ends up being a very simple yes, no in the guidelines. And just real quick, 2021 chest pain guidelines, it now advocates for coronary calcium as part of our chest pain guidelines. If they're low risk and they have stable chest pain, calcium testing is reasonable for excluding calcified plaque and identifying patients with a low likelihood of obstructive coronary disease. And as a same 2A recommendation for intermediate high-risk patients who have chest pain and have no known coronary disease and they have a stress test, adding a calcium test can be useful because you can find out if they have atherosclerosis and decide how to treat them. So calcium scoring is now creeping into the symptomatic population as well. And I'll just leave you with this group. These are patients that I advocate for calcium scores, intermediate and low intermediate patients, patients with a family history. We don't know the genetics. We can learn the phenotype, not if we don't know the genotype. If they're reluctant or intolerant to statins, it's remarkable how that changes when you show them they have a lot of calcified plaque. It may help us with non-statin therapy, making them secondary risk equivalents, things like PCSK9 inhibitors or icosapent ethyl. I think it's very helpful for aspirin. It's a great motivator of risk, and it's now even recommended for low-risk chest pain patients. Now, don't use it in calcium scores below age 40, and do not do an invasive angiogram if the patient's asymptomatic and has a positive calcium score. Even a high calcium score very well may have plaque along the artery wall and no obstructive disease. And I'll leave you with this concept. This goes back 5,000 years. Superior doctors prevent the disease. Mediocre doctors treat the disease before it becomes evident. That's subclinical atherosclerosis, coronary calcium. And inferior doctors treat the full-blown disease. And in this case, wait for a heart attack or stroke to start things like statins and aspirin and other therapies that may be very, very helpful before their first event. So I'll stop at this point. Thank Hattie for inviting me and turn it back over to our chairs.
What an impressive group of prevention presenters to our group today. Amazing. Thank you, Dr. Sky, Dr. Harrell, Dr. Budoff. We will now hand the meeting over to Dr. David Maron to facilitate. We are running about 5 minutes early. Thank you, Matt, for being ahead of schedule. And I'll leave it to Dr. Maron to decide whether he wants to go straight to opening the poll and having our bio break. It's in your good hands, David.
Thank you, Hattie. Terrific presentations. So thanks to all the speakers. And we have a debate coming up between Dr. Bob Kaplan and Phil Greenland. And there's a specific question shown on the next slide. Not a question, but a statement. There is sufficient research to support a strong recommendation to perform CAC scanning for risk assessment in primary prevention. And maybe what we could do is take a poll now. And I can't poll the audience. We don't have a poll to say if everybody wants to take a 5-minute bio break, but I realize that having an afternoon of several hours is difficult to do consistently. So let's see what we get with this poll. There is sufficient research to support a strong recommendation to perform CAC scanning for risk assessment and primary prevention. Please vote. And we'll give it a couple minutes. Unfortunately, seeing the results might affect those people voting. So, but the cat's out of the bag as far as where the preponderance of votes are going.
Do you want to take the poll down then and then put it back up after the bio break?
I want people to vote. And let's see how many more people we get, because I know that there are 87 participants. Okay, well, we're not moving the needle anymore. So clearly a strong vote in favor of scanning for primary prevention risk assessment. Jenny, please take the poll down now. And the results, in case you can't see the results, I thought everybody could see what I see, is that there was a vote of 86% of those voted said yes, and 14% said no. Thanks, Jenny. And you can take the results of the poll down. And what I suggest, since I can't poll the audience for taking a bio break, is to give you a few minutes of a break and to come back at 3:05 for the great debate. Thanks, everybody.
Are you guys coming to ACC, to DC?
Yeah, I'll be there.
Okay. Dr. Greenland, how about you?
I was hoping to come, but unfortunately I had some surgery a couple weeks ago, and
Okay.
so I'm still getting over that, but I guess I'll have to wait till next year.
Right. I mean, there's a lot of excitement now. It's the first major meeting in person in 2 years, so we're
Yeah,
excited.
yeah, really exciting.
Yeah. David, you going to be there?
I will be there.
Yeah, awesome. Dr. Mers? Yes.
I will be there.
Yeah, it's a lot of excitement. Yeah.
Okay, well, welcome back, everybody. I hope you had a chance to get out of your seat and move a little bit, and you're all ready for this debate. If we could go to the next slide, I want to show you the structure of the debate. First, Dr. Greenland will take the affirmative position for that statement. And then Dr. Kaplan will take the negative position, followed by his rebuttal, and then Dr. Greenland's rebuttal. Then the two debaters will have a chance to question each other directly. And then we'll open it up to our distinguished panel, where all can entertain questions from the audience and from each other. So it really is an honor for me to introduce our debaters. First, Dr. Phil Greenland is the Harry W. Dingman Professor of Cardiology and Professor of Preventive Medicine at Northwestern. He's a senior editor for JAMA and has held previous positions at Northwestern as the Department Chair of Preventive Medicine, Executive Associate Dean for Clinical and Translational Research, and Director of the Clinical and Translational Sciences Institute. He's been an epidemiologist in the MESA study very actively and is a longstanding member of the NHLBI Observational Study Monitoring Board for the Framingham Heart Study. Dr. Bob Kaplan was the Chief Science Officer at the U.S. Agency for Healthcare Research and Quality and Associate Director of the NIH. He's a distinguished emeritus professor of health services and medicine at UCLA, where he led the UCLA RAND AHRQ Health Services Training Program and the RAND CDC Prevention Research Center. He was chair of the Department of Health Services from 2004 to 2009. And prior to 2004, he was professor and chair of the Department of Family and Preventive Medicine at UCSD and was elected to the National Academy of Medicine in 2005. So we have very distinguished and experienced speakers, and it's time for me to turn this over to Dr. Greenland to take the affirmative position on the statement.
Great. Thanks very much to the Right Care Initiative for inviting me and for that introduction, David. Could you go to the next slide, please? So these are my disclosures. I have had some research funding related to coronary calcium, but no relations with industry. Next. So I want to introduce this as a clinical preventive medicine issue, and I think we've already heard a number of studies related to this. Can you go to the next? So this is related to a decision for individual patient care. Next. So we're not talking about population screening for the general population. What we're really talking about is making the best decision for the individual patient. Next. So that's where I'm going to focus my comments in this defense of the pro position. This is an issue relating to the best possible clinical decision. Next. So, and I want to reinforce that there is no practice guideline that says that we should be using coronary calcium for screening. The practice guidelines talk about using coronary calcium to refine the clinical decision. Next. So Matt Budoff talked about this previously. A lot of the discussion goes back to the American Heart Association ACC 2018 Statin Guideline. Next. So that was a guideline related to the management of blood cholesterol. And if you click next, the recommendation is here. Matt Budoff mentioned it already. In adults 40 to 75 years of age without diabetes and with LDL level between 70 and 189, with a calculated 10-year risk by the pooled cohort equation in that intermediate range that Matt talked about, the recommendation says if the decision about statin therapy is uncertain, consider measuring coronary calcium. And the next slide breaks this down. Matt showed this a little bit as well. If the coronary calcium in that intermediate group is 0, the patient is reclassified lower, and the patient would not be recommended for treatment. On the other hand, if at the bottom of the slide, if the calcium score is above 100, and Matt talked about this very clearly, that if the score is above 100, the estimated risk there would put the patient in the high-risk group, greater than 20% 10-year estimated risk. And so they're reclassified much higher, and they would be recommended for statin treatment. And if they test between 1 and 99, they don't get reclassified sufficiently higher to demand the need for statin therapy, but it could be considered. Next slide, please. Why do we think this way? It's based on this evidence from the cholesterol lowering trialist collaboration. At the bottom of the slide is the relative risk reduction using statin therapy from the trials. And in high-risk people, what's being shown in the slide at the bottom is people, men and women, greater than 30% predicted risk or greater than 20% predicted risk. And you can see in those two groups, there's about a 20% relative risk reduction with statin therapy. And because of the high risk at a risk reduction of 20%, those patients would, on average, be expected to benefit greatly from statin therapy. Next slide. So let's take a few minutes and think about how a doctor, a clinician, would typically decide to use any drug, but in this case, statin. If you click the first point. So my first premise is that in the case of statins, we already know, and this has been discussed previously, that the absolute benefit is greater in higher risk patients than in lower risk patients. So what we would want to do to try to identify who should benefit from a statin, we want to pick out the higher risk patient. Next slide. Now, this is a new point that others have really not talked about very much, but for a lot of clinical conditions, clinicians are expected to make their best guess. The problem is that when it comes to estimating high risk for a coronary event, clinicians are bad at doing that. And there was a study published in Annals of Internal Medicine, listed here in 1996, showing that if you ask clinicians to estimate patients' risk based on their risk factors, they don't do a good job at it. So the next premise, which everyone agrees with, ACC, AHA, US Preventive Services Taskforce, the European Society of Cardiology, pretty much everybody agrees that because doctors are not very good at estimating risk by gestalt, they should be doing it with some sort of test. And the test that's generally recommended is the pooled cohort equation or something similar to that. Click again, please. So that's what US Preventive Services Task Force and AHA and ACC recommend. But both of those groups say very clearly, this is an estimate. It's not a deterministic calculation. It's an estimate of the risk. And as we saw earlier in the presentation, in some cases, it could be regarded as not a very good estimate. So the next premise is that risk prediction can be improved by adding coronary calcium to the pooled cohort equation. And we've already seen evidence related to that, but I want to kind of hone in on a few aspects here in the next slide. So what we're talking about here again is this concept of treating the right patient at the right time with the right intervention. Next. So Dr. Budoff showed something similar to this. This is from the MESA study that's been mentioned before. These are the ROC curves. The bottom curves on both of these are Framingham risk score, which is equivalent to the pooled cohort equation, with a number of different tests added to the Framingham risk score, or let's say the pooled cohort equation. And you can see that whether you add the carotid intimal medial thickness or brachial flow mediated dilation or C-reactive protein, the curve basically overlaps with the Framingham risk score. But the very high ROC curve here is the addition of coronary calcium to the Framingham risk score. and we've heard this from Dr. Budoff, the evidence is very clear that adding coronary calcium improves the risk prediction. Next slide. So again, this is something that Matt showed. I'm not going to spend much time on it because of time, but if you start out with a pretest risk within any range at all, ranging from 0 to 20, if the coronary calcium score is 0, you markedly change the post-test risk. That's the bottom line on this curve. So whether the score is high or the score is low, you markedly improve the risk prediction. Next slide. So a few points that I think have not been covered yet in the previous talk. How important is it to get this right? Next slide. Well, the high risk proportion of the population, which we've been talking about a lot this afternoon, is actually much smaller than the low risk portion of the population. Next slide. So here's a distribution from the Haynes study. Click a few times, please. Next. So in the very high risk portion of the population on the right of the slide, only 10%. Sorry. Okay, I'll keep going here. The greater than 20% estimated risk is only 10% of the population. On the other hand, 36% of the overall adult population is in that intermediate risk group. And Matt Budoff already talked about this. This is a huge pool of patients in the indeterminate risk portion of the population. Next slide. In addition, and this is really important, no one's talked about this yet this afternoon, a majority of the cardiovascular events actually occur in the low risk portion of the population. So limiting preventive treatment only to the people estimated to be high risk misses a huge proportion of the population who could be prevented from having a heart attack. Next slide. So this is a graph from a paper published in the European Journal of Cardiovascular Prevention a few years ago, 2009. It's a distribution of risk on the bottom, and each of these bars is the number of cardiovascular events in the population. And you can see that on the left-hand part of the slide, most of the events in the population turn out to be in the low and intermediate risk group. Next slide. So further, getting close to the end here, statins actually may be more effective, relatively speaking, in lower risk people. Next slide. So this is again from the cholesterol trialist collaboration. And I showed you earlier the portion at the bottom, the greater than 20% and the greater than 30%, where the relative risk reduction was about 20%. But in the less than 10% risk group in all of these clinical trials, the relative risk reduction was actually much higher. It was close to 35% relative risk reduction. So there's actually evidence that by detecting these so-called lower risk people, we might actually be identifying the group that's most likely to benefit from statin therapy. Next slide. So therefore, since preventive therapy with statins is at least equally effective and maybe more effective across the lower portion of the population, next. And since the majority of the events occur in the lower risk patients, next. And if lower risk patients are misclassified by the pooled cohort equation, they won't be treated with statins, next. And since the US Preventive Services Taskforce and the ACC and HA agree that CAC is a valuable way to improve risk classification and identify higher risk people, it follows, I think, that the best way to improve risk prediction is by using the PCE followed by CAC when indicated. And therefore, my bottom line, it's clear that the evidence is sufficient to support a strong recommendation to perform CAC scanning for risk assessment in appropriately selected patients. Thank you.
Thank you so much, Phil. That was excellent. And now for the opposing view from Dr. Bob Kaplan.
Thank you. Let me see if I can share my screen. Are you seeing my screen?
We are, but we're not seeing the slides yet.
Let me see.
We're seeing an abstract.
How's
There we
that?
go.
You
Good.
need a slightly different format though, the different mode. Use the slideshow, I think might do it. We don't want
It may be that I've got.
If you end the show and click on a different, in the top left, if you end the show and go to the PowerPoint.
How's that?
It's not the.
It's I think it's the switching displays thing.
Okay, can you go to use slideshow? Try that. There you go. Okay,
That's good.
you're good.
So what do you see now? You see the
Yeah, you're good. See
good.
the whole
Okay.
thing.
Well, thank you. Sorry for that technical glitch. So I'm taking the con side, and actually, it's not really con. It's the maybe not side. And let me just begin by saying that this is a little bit intimidating for me. I mean, the debate with Phil Greenland, moderated by David Maron, my colleague, and following great presentations by Doctors Budoff, Harrell, and Sky. It's intimidating, and I should say that I'm not a clinician, but I have spent about the last 40 years or so as an investigator in randomized clinical trials. And I have worked on trials both for the NIH, for industry, and for agencies. You know, unfortunately, I'm not seeing my own screen. Let me see what I can do to get this back here.
Bob, what we're seeing right now is Face of Intimidation, the really wonderful photo that you found.
Yes, but so what I'm, oddly enough, okay, let me see if this does it. Great, okay. I've spent a lot of years as an investigator in clinical trials, and also teaching courses on methodology in both schools of medicine and public health. And I was the chief science officer, as David mentioned, at AHRQ, and that's the agency that oversees the U.S. Preventive Services Taskforce. So I just want to begin this by conceding a couple points. So these are issues, as far as I'm concerned, that are not on the table. First, there's no challenge to the accuracy of the CAC test. And so presentations today by Doctors Budoff, Harrell, Sky, and many others, I think have made it abundantly clear that CAC is a very good predictor of outcome, and it's a great way to reclassify people. And also, there's no challenge to the value of interventions for secondary prevention based on ASCVD scores. But the U.S. Preventive Services Task Force focuses on primary prevention, and that is prevention for people who don't have symptoms. Now, one of the big questions that I think that we need to address today is, does knowing one's CAC score change prognosis? And again, the U.S. Preventive Services Task Force has not found high quality evidence to support this assumption. And I'm going to try to get into why. So I think many of you know that back in 2018, the task force looked at what they called non-traditional risk factors. And so they looked at ankle brachial index for people with peripheral vascular disease or suspected of that. They looked at high reactivity, C-reactive protein, and then they looked at CAC scores. And one of the things that they concluded was that there was only at the time one randomized clinical trial involving about 1,000 people that found no benefit for CAC guided moderate intensity statin at approximately 4 years. But the study was really not powered to evaluate these outcomes. So when we look at treatment options, and again, the task force looks at two twin objectives. One is the test any good? In other words, does the test improve classification? And I think we've already conceded that point. Matt and others have made this point very clearly. But then if there is an elevated CAC score. Well, what do you do about it? And there are about at least four options. One is PCI and coronary artery bypass graft surgery. And the way I read the literature, based on the ischemia trial and Courage and others, is that there isn't clear evidence to go in that direction. But I'm going to defer any questions on that to the moderator of the debate, who knows much more about this than I do. The second option is cholesterol lowering. The third is aspirin. And the fourth is lifestyle. Now I'm going to spend most of the time today on evidence for the benefits of cholesterol lowering. I just want to point out that this is somewhat controversial, that there was a paper in JAMA Cardiology a couple of years back by one of the associate editors of the journal saying that statin skeptics were the same as anti-vaxxers, which I think in the great hierarchy of status, that's probably just a notch above child molesters. But I've heard repeatedly that nobody in their right mind challenges the value of statins. So let's have a look at the data. Well, first, let's have a look at this scattered diagram. And we ask, well, how strong is this relationship? And so if you were to sort of just eyeball this, is this something that you would find to be a persuasive relationship? And what you see here is the treated and control groups or different doses of statins across many trials. And the points are all over the place. And then we get slides like this one. This one actually comes from an Amgen ad for their PCSK9 inhibitor. And you can see here that the points line up along this line, and that it suggests that the relationship is quite linear. And in particular, that it doesn't matter how low you go. So that reducing LDL cholesterol from 200 to 150 is about the same as reducing it from 100 to 50. And this has guided a lot of thinking on this issue. How low can you go? Well, it doesn't matter, because the lower you go, the better off you are. So to get a better sense of this, we can look at the source for this diagram that was cited in the Amgen ad, and it's a paper by Raymond. So let's go to the Raymond study. Well, here it is. So what you see is that same scatter diagram without the two lines in it. And you can see that on the top of it, there's a blue line, and that's fitted to the secondary prevention studies. And then there's a red line that's fit to the primary prevention studies. And I mentioned earlier that we're trying to focus on primary prevention studies. That's what the U.S. Preventive Services Taskforce has as its mandate. So what they've done is they've just disregarded the primary prevention studies and looked only at the secondary prevention studies. But in addition to that, the points are very cherry-picked. In other words, these are not all the studies. This is a selected group of studies. And particularly on the right, studies were selected and groups within those studies were selected to just line up on this line. So to avoid cherry-picking bias, we need to look at all the high-quality studies, not just the ones that fit our particular hypothesis. And that's what the U.S. Preventive Services Task Force does. So as many people know, the task force now has in play their recommendation for statin use in primary prevention. And in doing this analysis, they look at all the studies. They have a very systematic protocol for identifying what studies to look for. And then they have inclusion-exclusion criteria, but those are all decided on, posted, and evaluated in public hearings before the review ever starts. And what you'll see is that there actually is no trial, and I should say that again, there's no trial using the current evidence that shows that statin medications lower the probability of death from cardiovascular disease in primary prevention trials. And if we look at all-cause mortality, there are two studies, ACAPS and Jupiter, that do show that there is a benefit of statins. That's 2 out of about 13 or 14. And in both of those cases, both those trials, the benefit is just right on the borderline. So if ACAPS, for example, the upper limit of the 95% confidence interval is 0.99. If it was just 100th higher, it would not have been statistically significant. Similarly, Jupiter is just right on the borderline. So how do we look at this, or how do we make sense of this? Well, we look at typically relative risk, absolute risks, and number needed to treat. So with regard to relative risks, there's maybe an 8 or 9% benefit for statin therapy across all the trials. But I think from the patient perspective, what we're really interested in, me as a patient and other people as patients want to know, what is my probability of benefiting from this medication? So for all-cause mortality aggregated across these studies, it's about 0.4%. And for CVD mortality, it's about 0.2%. So if we look at the numbers needed to treat, you need to treat 231 people with a statin in primary prevention to avoid one death from any cause, and 591 people to avoid one case of all-cause mortality. So another way of thinking about this is that if you're a patient, your chances of preventing your own death are about 1 in 231 for all-cause mortality, and it's pretty close to 1 in 600 for CVD mortality. But wait a minute, US Preventive Services Taskforce is way out of line in comparison to other objective reviews, right? Well, let's have a look at that. First of all, the US Preventive Services Taskforce, I have to admit some bias having worked with them, but they are funded by a government agency. All their reviews are completely original. They're done by professional evidence-based practice medicine centers who it is their job to reduce bias and to use all of the latest techniques for doing unbiased systematic reviews of the literature. They operate in complete transparency. The review criteria are posted for public comment. Draft reports are posted, and everything is open to public comment. And so before they ever post a final result, they've had a period of public comment and rebuttal. And anyone, and I mean anybody, can replicate what they've done. So data are made available to anybody who wants to try to replicate their analyses, and that happens. In contrast, most other guideline groups depend on the cholesterol treatment trialist group. And that is the basis for the AHA and ACC guidelines, the European guidelines, and others. And this is done largely because it's really expensive to do these systematic reviews. And most people just don't have the resources to do them. So let's look at the CTT. Well, first of all, it's funded exclusively by the pharmaceutical industry. There's a lot of people say absolutely no transparency. The data are the property of the CTT, and they're not shared. And this is by contract with the industry sponsors. CTT does not allow anybody outside their group to independently verify their calculations. And this actually has been tested in a lawsuit to the British Medical Journal. And the BMJ actually got 2 outside statistical consultants to look at it. And in both cases, they concluded that there's a serious problem with the transparency of the CTT group. And there are other systematic reviews. This one was published in JAMA Internal Medicine about 2 weeks ago. Again, they followed all of the standardized methodologies. They used the Cochrane methods. They followed the National Academy of Medicine guidelines, and they prospectively registered their study, and they found about an 0.8% benefit for all-cause mortality. There also was a big systematic review done in the UK a couple of years ago, again, following the Oxford standards. Again, same result. It looks the same as the US Preventive Services Task Force and the recent JAMA Internal Medicine group. And I think it is worth saying that this UK evaluation came up with something interesting. They said the effects of statin therapy on survival give you about 1 day of life for each year that you take statins. So for example, if you take statins for 20 years, you'll extend your life expectancy by about 20 days. Now, if we look at the estimated benefits of the USPSTF review versus the cholesterol treatment trialists, USPSTF said the absolute risk reduction is about 0.4%, a very, very tiny amount. Interestingly, the CCT review is about 0.1%. It's about a quarter of the tiny benefit that USPSTF suggested. And here's where it comes from. My colleague John Abramson and I are sort of nerds, and we look at all these data in great detail. And usually what we look at is not what everybody else looks at, even though it's public. So when the treatment trialists published their paper in Lancet in 2009, they're required to put in a statistical appendix, and the appendix is very long. And on page 60 of the supplement is where they actually reported the absolute risk reduction for statins. So you can see it's that deaths were 2.3% in the control group and 2.2% in the treatment group, about 1/10 of 1%. In other words, your odds of benefiting if you're a patient are roughly 1 in 1,000. Now, to just wrap this up, that there's more than cholesterol, there's aspirin. And so this is the USPSTF most recent review on the benefits of aspirin for all-cause mortality. And as you can see, there is absolutely no benefit for all-cause mortality from aspirin use. By the way, this is still in play with the Taskforce. The preliminary recommendations are posted, but the final recommendations are still not out yet. And then there's dietary intervention. Interestingly, dietary intervention does lower LDL cholesterol, and that's aggregated across studies, but that's LDL cholesterol, that's not mortality. So by way of conclusion, I think I may be over my time. So let me just wrap this up by saying that the USPSTF, in my opinion, is the most transparent and independent source of guidelines for screening and tests for people without symptoms of disease. And people say, well, we can't do things because the USPSTF didn't give it an A or a B. But actually, among all the things that are done in preventive medicine and primary care, it's actually very rare to get an A or B. There's only about 50 things that have been studied out of literally thousands of potential interventions that get an A or a B. And providers can offer CAC to their patients. There's no prohibition against that, and insurers are free to cover this if they want to. They certainly cover all sorts of other things that are not recommended by the task force. But the task force decisions have very profound financial costs. And so the task force really needs to be quite conservative about what they recommend. So I think, David, I might have gone over my 12 minutes by a minute or two. I want to thank you again for inviting me, and I look forward to the discussion.
Thank you very much, Bob. It is your turn for rebuttal. That was a great presentation. You're in a tough spot because you saw what the initial polling was, and let's see if you can change, bend the curve. Do you have additional slides for your rebuttal?
No, I'm gonna speak from some notes that I've taken here.
It's Bob's turn for rebuttal.
Oh, okay. I will be quiet then.
So, Bob, do you have slides for rebuttal?
I'll just make a couple points. I had extra slides, and David, stop me when I get to my 3 minutes.
Okay.
I want to say that a lot of where I'm coming from comes from having been a blinded investigator in a lot of trials, and also from being a DSMB member. And what's different about that is that you, as a DSMB member, you see the outcomes, but you actually don't know which treatment is which. So like on this slide, for example, as a DSMB member, you know that one treatment is performing better than the other, but you're not encumbered by knowing what the treatment is. So on the right of this slide is a lot of trials I've worked with over the course of time. Among these, only one of these trials actually produced a result that was expected. And so I do want to just make the point that we have to let the evidence speak. And we think the evidence is not in yet, even though it's likely that additional clinical trials will show the benefit of CAC for outcomes. Studies just haven't been done. One other comment I wanted to make is this issue of how low can you go, or do you need to go? And again, we hear repeatedly that, well, it's a linear relationship. So going from a high level to a lower level is the same regardless of where you start. And I think that's not true. I think that the cholesterol treatment trialists had a sleight of hand on this. So here you see these lines for people at different ages. But what they didn't point out, or what's, I think, the sleight of hand, is that the y-axis is actually a logarithmic scale. So this is not a linear relationship. This is a log linear relationship. And the trialists actually mentioned that they decided not to consider these off-diagonal points at low cholesterol levels. So just going back to this slide, if you start at a high LDL level, then there's significant benefit from cholesterol lowering, as you see that in 4S and other studies. But if you start at a relatively low level, there's not so much of a benefit. And again, these are observational data from Israel, but I think a variety of lines of evidence suggests that, people who might have low LDL levels to begin with might not benefit much from additional intervention. It does not get at this issue with being at risk because of high CAC. And I think that that's something that we need to devote more attention to in the debate, because I think we just don't know. So let me just stop there.
Thank you, Bob. And if you could please stop sharing your screen. And we can go now to the rebuttal from Dr. Greenland.
Okay, well, that was a great presentation, Bob, and I want to congratulate you for pointing out the methodology of the U.S. Preventive Services Task Force. What I want to direct some attention to is that I think the U.S. Preventive Services Task Force is high quality, but I think some of their conclusions are very inconsistent. And on this particular topic, I think particularly inconsistent. So in 2018, when they reviewed the non-traditional risk factors for cardiovascular risk assessment, they said that cardiovascular risk assessment has generally been based on Framingham risk score, and more recently, the pooled cohort equation. And they said that the reason that such tests as coronary calcium might be of interest is because there was evidence that they might improve risk prediction. And then they gave it an I rating. And in the comment period, several comments noted that the addition of the non-traditional risk scores, risk factors, especially CAC, was useful for patients for risk stratification. And so people were unclear, why did the U.S. Preventive Services Task Force give it an I? So they came back and they said the task force didn't find convincing evidence that adding non-traditional risk factors, and I'm quoting this directly from the statement, the U.S. Preventive Services Task Force did not find convincing evidence that adding non-traditional risk factors to traditional risk factors improves reclassification in intermediate risk groups. Well, we just saw evidence of that in multiple studies. And my co-debater here, who did a great job, pointed out that that was not even a debatable point, that we already know that that's true. I want to fast forward to the statin guideline that's in draft form from the U.S. Preventive Services Task Force, and I want to read some of the quotes from that. They said, again, that ACC and AHA pooled cohort equation may be used to estimate 10-year risk of CVD in terms of making the decision about statin therapy. And then they said clinicians should recognize that the predictions of 10-year CVD risk events using the pooled cohort equation are estimates. They then said the likelihood that a patient will benefit from statin use depends on the person's absolute risk of having a future cardiovascular event, a risk estimation that is imprecise based on the currently available risk estimation tools. They then said the higher a person's 10-year risk of a CVD event, the greater the chance of benefit. The benefit we're talking about here is the benefit of statin therapy, which even the U.S. Preventive Services Task Force said was real. Then they said for patients with an estimated 10-year cardiovascular risk of 7.5% to 10%, and who have one or more risk factors, clinicians may selectively offer a statin. They further said patients in the estimated risk range who place a higher value on potential benefit may choose to take a statin. Now, based on what we saw previously from data that were presented about coronary calcium and risk assessment, it would seem logical that the U.S. Preventive Services Task Force would say, how do we best estimate risk of who's high risk and therefore choose a statin if there's any doubt about absolute risk? Well, as we've seen, the evidence seems to favor use of coronary calcium in that uncertain group. Let me read a couple other statements because I think they're really important in showing that the U.S. Preventive Services Task Force is actually a little bit inconsistent here. They say that no study has directly compared effects on mortality or cardiovascular events from the use of coronary artery calcium. Well, that's also true of the pooled cohort equation. There is no evidence that using the pooled cohort equation leads to better cardiovascular outcomes. So why apply a different standard to coronary artery calcium? They also say that in the 2018 review, they found that the addition of CAC score can improve both discrimination and reclassification. So again, if they acknowledge that that improves risk reclassification and discrimination, why would they recommend the inferior test? So to conclude, I think that I still think that the evidence supports several statements. Number one, that both the U.S. Preventive Services Task Force and the other guidelines agree that coronary calcium is a valuable way to improve risk reclassification and identify higher risk and lower risk patients. So it would therefore seem to follow that the best way to improve risk prediction and selection of patients for statins would be to use the pooled cohort equation, followed by coronary calcium in those intermediate risk patients where the decision is somewhat uncertain, which is even something that the U.S. Preventive Services Task Force recognizes. So my bottom line is really the same as where I started. Sufficient evidence, I think, supports the use of coronary calcium in selected patients. And I think that's even consistent with the recommendations of the U.S. Preventive Services Task Force if they were consistent themselves.
Thank you, Phil. So you got a little extra time on that rebuttal. You now have the two of you 5 minutes to ask each other penetrating, difficult questions, and then we'll open it up to a broader discussion. And as far as who gets to ask someone first, does one of you have a burning question for the other? Bob, go ahead. You're on mute.
Yeah, Bob, you have to unmute or I'm going to lose that point.
Oh, so first of all, I started my comments by saying this is really intimidating, debating with Phil, and that you can see why we invited him. That he did a terrific job. But let me start here with a question. So again, USPSTF as a tradition looks at screening tests. By the way, so they don't do diagnostic tests. So they're focused on screening tests that are used in primary care for people who don't have signs and symptoms of disease. And that traditionally the way they do this is they look, number one, does the test predict outcome? And I think that we're in agreement that CAC does a great job in reclassification. But the second dimension is, does knowing that information results in some sort of course of action that results in better patient outcomes? And that's the point where I'm not sure that we have the answer. And again, it isn't just risk, but it's actually coronary calcium, which is different than the other risk factors. And so I believe that what they're waiting for is the randomized clinical trial that uses CAC screening, identifies people with high CAC, perhaps even high CAC but low ASCVD scores, and then randomly assigns them to treatment or control. I don't know if that's more of a statement or a question, Phil, but
yeah. Well, I'm going to step out of the debater role a little bit here and just try to answer a question as, you know, if this was grand rounds or something. And where I think that I might differ with the U.S. Preventive Services Task Force is the notion that, first of all, if there has to be a choice about who to use statin therapy, and I think there should be a choice about that because the evidence is reasonably clear that giving statins to everyone would not be clinically rational and it wouldn't be cost effective. And the cost effectiveness analyses have looked at that pretty carefully, and they've concluded that, you know, using statin in everybody, even if it's very, very cheap and very, very safe, doesn't make sense. So we're not going to put statin in the water. So the next step in this decision-making process is how do we decide when to use statin therapy? And everybody says, and even U.S. Preventive Services Task Force comes up with a recommendation about that. And what they say is, let's start with a pooled cohort equation. But oddly enough, then they come along and say, well, actually, the pooled cohort equation is not a very good way to select people. And then they further confuse things, in my mind anyway, by saying, well, there's this other test that actually works better. So that's where I'm a little confused. If I were asked this question at grand rounds, let's say, I would say, based on what I know, the best way to classify risk, the best way to identify high-risk patients and separate out the low-risk patients would be not to give CAC in everybody, because I think that's a bad idea, and no one's recommending that. But in this large intermediate risk group, where we know that there's a lot of patients in that intermediate risk group who are going to have events. And that's something that also gets a little bit muddy in this argument, is that people who are called low risk are not no risk. And as I showed on that one slide, the intermediate risk group is probably 35% of the population, but probably 60% of the events. So it's really important to be able to figure out which of those people might be actually higher risk than they appear to be. You know, I don't differ with the methodology of the U.S. Preventive Services Task Force, so I highly respect it. I just think that for this particular clinical decision, they probably shouldn't have weighed in, because like you said, their job is really to look at things like screening. And it might have been better if they had just said something along the lines of, no one recommends coronary calcium for screening, and neither do we.
Bob, do you have any closing comments before we do a repeat poll to see how the audience thinks now?
I think that the major issue, again, is that we may be getting close to having a randomized clinical trial on the benefits of intervention for people with high CAC, and they may be people with high CAC, but not necessarily high ASCVD or Framingham scores. But until that trial is done, I don't clearly see that there's a benefit, and that I think that we'll have that answer relatively soon. I do have to say that there have been times in the past where the task force has made recommendations prematurely, and once you make a recommendation, it's very hard to pull it back if new evidence comes along. And in this case, I think that we're close to having the evidence, but we just don't quite have it yet.
Thank you, Bob. Jenny, can you please pull up the poll, the statement to have everyone vote?
Yes.
Again, there's sufficient research to support a strong recommendation to perform CAC for risk assessment and primary prevention. please vote. We'll give it another few seconds. Okay, well, I think that there's a good outcome for everybody. It looks like the preponderance of votes are still in favor of CAC, but the number of positive votes is less. So I don't know how to define who won the debate, but it was a great discussion, and I think it should continue now with this panel. And so, you know, I feel like I skimped both of you on your introductions because I was trying to save time, but it really, you are both such great scholars, and as your debate demonstrated, gentlemen. And we have a panel of really very distinguished people. And if I took the time to introduce everyone, it would be time to close. So I'm asking the panel to forgive me for not introducing each of you individually. And I think that we should go to questions from the audience. And I see questions, and I'm just going to take them in order. Is there any benefit of repeat calcium score if the patient is on a statin and there's already a coronary calcium scan that's been done and the score is 0? And if so, how often should the CAC scan be repeated? This might, any one of you could answer this question, but I'm going to ask Matt Budoff to answer that one.
Yeah, so generally, we advocate a window of 5 years. If the score is 0, to wait generally 5 years before repeating it. And that's in the 2018 prevention guidelines as well, to reassess in 5 years.
Thanks. And thanks for your brief answer, because that way we'll be able to get to lots of questions. But a follow-up question is, most say not to repeat the CAC if there's a CAC score greater than 0. And based on this, is it essential to do follow-up testing to see if it's over 300, since that's a coronary disease equivalent? So I'll ask you again, Matt, to respond.
So if the score is 1 to 99, you're still in that kind of indeterminate range. And again, it's recommended to repeat the score to see if they cross the 100 threshold, because that would then theoretically change your underlying risk of your individual patient, and you would up titrate therapy or initiate therapy if they weren't already on it. I'm an advocate of following calcium scores, not annually or anything like that, but at some interval, maybe 2 or 2.5 years. And you'll see some new guidelines from smaller societies that will advocate that, because there's really good evidence that if your calcium score is going up significantly, 20% a year by 100 points, that you're at a markedly increased risk. And I think we have so many good preventive tools to use on the top of statin that you can add therapy if you found out your patient was higher risk than you thought.
Does anyone on the panel want to make any additional comments? And I know that many of you are thinking, well, wait a second. If you're treating intensively, the score is going to go up because the calcium density goes up. And that's not associated with yet a higher risk. Any comments from the panel?
You know, Matt's data is observational, so I think you would need to look more carefully at that. And it's another reason we need a randomized controlled trial.
Yeah, this is just a further clarification question from Matt. So you said we have lots of great preventive care tools other than the statin. What are those other great preventive care measures?
Yeah, so, you know, I mean, we've typically just said, oh, statin, and when you've maxed out on statin, you're done. But now we have multiple therapies that have been proven to add incremental benefit to statin therapy, depending on their other, you know, LDL or lipids. So we have icosapent ethyl as a potential treatment if their triglycerides are high. We have PCSK9s that have outcome data that prove that they add value to a statin. In the diabetes realm, we have SGLT2s and GLP-1 receptor agonists that have proven incremental value on top of statin therapy in randomized trials. And I totally agree with Noel's comment. It's important to do more prospective studies to further validate this, but I think we have a large observational pool of data that shows benefit. And I'll tell you, there is a randomized trial going on with coronary calcium right now called Vesalius. It's an Amgen study adding PCSK9 or not. And one of the entry criteria is a high calcium score. So we will have randomized trial data to support that algorithm of care if that trial's positive.
Gary Conrad asks, in an asymptomatic patient with a CAC of 1,000 and diabetes, how often do you order a stress test, and should it be a perfusion scan? Anybody want to take that one on?
It's an ischemia trial question, David.
Don't forget
Well,
back to David.
Not really. This is an asymptomatic person with a high calcium score. That person would not have been enrolled in ischemia. Should a stress test?
You don't know that they don't have ischemia, and you had plenty of asymptomatic people in ischemia.
This is true. I'm ducking the question because I want to involve our panel. Dr. Rana, would you like to take a stab at that?
Yeah, so based on the latest chest pain guidelines, we have seen, and others can chime in too, that we are moving more towards anatomic analysis and not so much treating ischemia. So previously, anybody who had, I trained with Dan Berman, anybody who had calcium scan of 400 and more, we will automatically start ordering MPI scores. Currently, in my practice, if somebody is not having symptoms and it was asymptomatic high CAC, we just treat it with statin and potentially aspirin and don't necessarily start doing the stress tests unless they have some symptoms.
So let me ask Dr. Balmer, you take a patient like that with diabetes who's asymptomatic, and maybe the diabetes means they have silent ischemia and they have a really high CAC score. And let's say you're referred the patient because they have had a stress test and it's abnormal. What are you going to do with an asymptomatic patient with a high CAC score who's got ischemia on their stress test?
Well, the concern that I have is actually left main disease, which is a little bit uncomfortable. And I don't have, so there's a couple ways of looking at left main disease. We looked at left main disease and found that almost all of them, 90% of them, had a positive EKG treadmill of greater than 1 millimeter of ST depression. So that was a ischemia level, looking at identifying not ischemia so much, but trying to identify a high-risk population, which is left main disease. Left main disease with ischemia potentially has a higher risk, which was not answered in the ischemia trial because those were ruled out by CT angio at that time. So we really don't have good evidence in those individuals. So I'm not comfortable sitting on left main disease or the equivalent findings of left main disease with ischemia, where I can say, okay, we can do nothing, because there was some evidence in those earlier trials that intervention, revascularization specifically, had some benefits in a diabetic population for that. So clearly, if it's a high-risk individual and I cannot rule out left main disease, and I have suggestion of it, which is a significantly positive EKG treadmill based on limited data that we have in a population for that, then I would probably consider further analysis, including CT angio. And if they did have left main disease, it's a patient decision, clinical decision. I would sit down with a patient in the presence of diabetes and left main disease and suggest the possibility of undergoing intervention, which would be coronary artery bypass graft surgery, really prophylactically or preventatively at that point in time, since they were not complaining of active chest pain.
Thank you. I'll mention that we recently published from the ischemia trial among patients with moderate to severe ischemia on a stress test who underwent coronary CT angiography that we were not able to identify with a an adequate amount of accuracy those people who had left main disease. So in other words, abnormal stress test, you can't really tell from the stress test finding whether or not they have left main disease. But let me ask a related question, and we're getting maybe a little off topic, but if people are thinking about, gee, do I need to get a CT angiogram on somebody with an abnormal stress test? What if they have a calcium score that's high, but there's 0 calcium in the left main? What are the chances that they have obstructive left main disease?
Well, I think the answer to that is Matt Budoff. So he probably has those numbers in his head right now.
I would just say that the location of CAC is not as predictive as we would like it to be for obstructive disease in that vessel. So I'd be a little bit nervous about saying there's a lot of calcium in the LAD, but none in the left main, therefore they can't have left main disease. Because again, it's that 20% rule is 20% of total plaque burden, but not in any given segment. So I mean, if you have a lot of CAC in the left main, that's bad. But the absence of CAC in the left main may not be as good as it sounds.
Here's a quick question, and it's probably to you, Matt. Is anyone using icosapent in patients with a high CAC score? Is there any trial?
Yeah, so unfortunately with the patent going away or losing their patent battle, they're no longer funding large trials anymore. We have, so I don't know if there's going to be great prospective randomized trials, because as you know, good or bad, without pharma funding a lot of these studies, you could look at Bob's slide, and if you took away all the pharma studies, he'd be showing no relationship between cholesterol and lowering cholesterol in events, because there'd be no other trials left. So we just won't have that data because pharma's not doing them anymore.
Okay, thanks. Dr. DeMaria.
Hi, excuse my appearance. I'm fresh from clinic. In any event, I just wanted to bring up a topic. In my experience, people with the highest CAC scores are most likely to have equivocal CT angios. It's really been a problem. You have these patients and you'd like to do something to know, do they have severe triple vessel disease, left main, or something along those lines. And the interpretation comes back really mushy, and clinical correlation indicated. I don't know if that's a universal experience or not.
Well, I would just say real quick, Tony, and great to see you. That is a problem. Calcium scores generally above 1,000 are known to be a little bit less diagnostically accurate. You get shadowing and other problems from high calcium scores. There is FFRCT now where you can get fractional flow estimates, and that might be helpful in those higher scores to give you a little bit better data. But I would say that's a good place for a functional test if you're worried about multi-vessel disease. That's where I do a nuke or a stress echo.
Dr. Wong, there's a question here. So if you have, I think, an ASCVD risk of 15 to 17%, which the questioner assumes indicates low to moderate risk or intermediate risk, then a statin may be worth taking? Question mark?
Yeah. So remember that our current guidelines would recommend consideration of a statin in that intermediate risk range with discussion of possible risk enhancement factors. So there are a lot of risk enhancement factors, as you know, including things like persistently elevated LDL, high triglycerides, elevated LPA, and other certain things like family history. So a lot of people will have those. So, one needs to do appropriate clinician-patient discussion for those individuals. Certainly, this is the range of risk where a calcium scan could certainly be useful, because clearly if the score is over 100, one of those individuals in that range should definitely be on a statin. I do want to make one comment regarding the Preventive Services Taskforce data that actually Dr. Kaplan very nicely presented. Those data were looking at the number needed to treat. However, we're really focused on cardiovascular and total mortality and those primary prevention trial data that he presented. So I would question whether that's really the appropriate endpoint, because we're interested in non-fatal MIs and strokes and other forms of ASCVD, and not just total or cardiovascular mortality, for which many of those trials were not powered. So I would just want to bring attention to the fact that the number needed to treat and the lack of clear efficacy of statin in those populations were really due to applying a very stringent endpoint. And we care about a lot more than just total mortality and cardiovascular mortality, although those are certainly very important. But we care about other events too, and that's what calcium scanning is all about, trying to identify the risk of any event, and not just total or CVD mortality.
And thank you for raising that. So 12 minutes, you can't fit very much in, and you're absolutely right that if you look at the evidence for non-fatal MI and stroke, then in fact there's greater benefit for statin. And it gets at this more complicated issue of what the endpoint is in a lot of clinical trials. So consistently across trials, there is a benefit for non-fatal MI, and that what happens is that trialists have gone to using these composite endpoints. So it's non-fatal MI, non-fatal stroke, cardiovascular death, all-cause mortality, and so forth, and they get added together, and depending on the trial. And that it's, your point is very well taken, but it's also very confusing to determine exactly what's in those composite endpoints or how they should be interpreted.
Dr. Vora.
Hi, everyone. Good to see you all. Sorry I was in and out today. So I'm a stroke neurologist here at Stanford, for those of you that I don't know. And I'm also interested in health in women and in the younger age groups, and as well as South Asians. And so my question really had to do with, Matt, you presented this very eloquent, CAC equals 0, no need to treat, that's ridiculous kind of statement. But I do want to ask about younger women or younger folks with intermediate risk who have some risk enhancers. Could CAC 0 underestimate their risk because they haven't calcified yet? I thought I remember reading that. So I'd love to hear from you on that and from others as well.
Well, yeah, I would just say briefly that we just don't have a lot of data in younger than age 40 for coronary calcium. Somebody's playing music, I think, but anyway, but younger than age 40 is a problem. And if they have calcium, it's bad. If they don't have calcium, it's not definitive. I'd be nervous about under age 40 for men or women, regardless of ethnic diversity.
Nervous to utilize a CAC 0 to reclassify.
To rely on a CAC 0.
I think that's an important point that we should include in all of these slides. I don't know if it's, maybe I missed it, but I think we have to
I had it as a caution in my CAC talk. I added that as a CAC age less than 40 is definitely an issue where I don't rely on it. But if they do have CAC, if you do it for some other reason where they get it at 32 and then calcium, that's really bad. Because their age-adjusted score is very high, right? Very high.
I would also comment briefly that, in certain groups of individuals under the age of 40, where CAC may have not yet developed, such as some people with familial hypercholesterolemia, perhaps if they have chronic kidney disease, I would, or other high-risk conditions such as long-standing diabetes. I would not want to withhold statin therapy just because the plaque was zero. They may still have soft plaque that could become clinically significant.
Dr. Rana?
Yes. So Nathan, I think you can you mute yourself? Thank you, Nathan. Yeah. So I have a very, personal story to share, and I was really looking forward to today because one of the best minds in the nation are here. So it's regarding to USPS, their guidelines and how its screening is noted. So recently, a friend of mine who's a physician, female, who was 46, and based on new guidelines, she got a colonoscopy, and early on they found a polyp and cancer, and she was treated and she's doing well. So that's a good outcome of screening in young patients or asymptomatic people where screening was able to find something. I have another friend who's 51 years old who had a huge MI, and he died because he went to the hospital and they found plaque all over. He was asymptomatic till the date that person had an MI. So I think the question here is, when we talk about primary prevention, to Dr. Kaplan's point about when purely primary prevention, we try to treat patients with statins and maybe we didn't see that much effect. When I see somebody with 400 of calcium scan, I don't think it's primary prevention at that stage. Those people already have coronary calcium. They already have coronary disease in my mind. So it's already like either it's primary prevention 2.0 or it's pre-secondary prevention stage already. So what are people's thought on like the same concept as screening for colon cancer? You find a polyp, then they have something, you treat it. And then again, when you screen with calcium scan, or let's say Dr. Greenland's point, the intermediate risk, we do the calcium scan. Once they have calcium scan, then there is a role of statins and lifestyle changes, just the same way we intervene in colon cancer. So any thoughts on that? It's for everyone, not just anybody can take that.
First of all, I think that's a very good point, and that the colorectal cancer screening guidelines, they've just recently changed them. They reduced the age from 50 to 45. And I think it's a very good point. And the issue is that screening leads to this course of action where people are likely to have a better outcome. And that again, that's the issue that was raised with regard to coronary calcium screening, that some people, I think that there's a lot of difference of opinion about how to interpret the existent data, but some people feel that we still are waiting for the trial that shows that people identified as having high CAC benefit from intervention. I just want to make one other point, because there have been several comments about identification of younger people. And one of the issues that we didn't get into today was actually the reverse of that, and that's identification of older people. And that if you look at ASCVD scores or other risk calculators, then it becomes very difficult to get below whatever threshold, if it's 10 or 12%, if you're above a certain age. I think it's about 68 or so if you're a male. And the USPSTF, in their draft guidelines that just came out with, said, well, what should we do for people that are over 70 or 75? I can't remember if the cutoff was 70 or 75. And they punted on it and they said there's just insufficient evidence. And actually, if you dig into that literature, they're just, again, no trials or a couple trials that are in process, but the available evidence just doesn't provide enough meat for them to make a recommendation. I was curious about how people react to that.
Well, maybe I could take a shot at that. I think that it's correct to say in people 75 and older, and getting really close to that myself. The trial evidence for statins is much thinner than it is for younger people for primary prevention. So, I mean, part of the issue here is the confusion related to the fact that so many people will be classified as high risk by age alone. But the other problem is, what's the evidence that we have that statin therapy is beneficial in older patients? And so there are at least a couple of trials now that are going on. One is called Preventable, which is funded by the National Institute on Aging and partly by the Heart, Lung, and Blood Institute, trying to randomize people age 75 and older to statins or no statins. It's a huge trial. They're trying to recruit 20,000 people. And that tells you something right there, that if you're trying to recruit 20,000 people, presumption is that it's actually a fairly low probability event that you're trying to prevent, right? Otherwise, you would need a much smaller sample size. And there's another trial that's going on in Switzerland, which is sort of the opposite of that, which is subtracting statin therapy from people over the age of 75 who sort of aged into the use of statin therapy in that age group. So the second trial, the Swiss trial, is trying to see whether stopping statins in that age group is deleterious. And the American trial is trying to see whether adding statin is beneficial. But I think it's very true that in that older population, we have a problem with risk assessment, and we also have a problem with less robust data about the benefit of statin therapy.
Now, there are 3 raised hands, but they are all from people who have already asked questions, so I can't tell if they're new or old. Doctors Balmer, Demaria, and Vora. Do any of you have a question that you wanted to ask?
David, I had a question related to, we've talked about the fact that coronary calcium scanning identifies a population to either start a statin or end a statin or stop therapy, or perhaps add additional dyslipidemia therapy for it. So we're talking about a relatively, and Bob Kaplan pointed out, a relatively small absolute risk reduction of adding statin, literally a fraction of a percent for those individuals. In the situation where we look at benefit, we should also look at harm. Is there a harm associated with making this decision? Because coronary calcium will potentially deselect more individuals from taking a statin than necessarily add statin, because a greater percentage, 30, 40%, were found not to need a statin, i.e. with coronary calcium of 0. So in the situation of aspirin, we look at the number needed to harm is significant. And in fact, in even moderate individuals, the harm from aspirin may be greater than the benefit of aspirin in that population. Is there a trigger or number for statins where we think the number needed to harm is high enough that it would counter the number needed to benefit, which Bob showed in some populations was hundreds, 400 or 500 patients needed to be treated? Is there a trigger number needed to harm where that is equivalent? So just like aspirin, we have a threshold above and below which therapy is recommended, and statin helps us, or coronary calcium helps us derive at it. Is there a similar threshold for statins where number needed to harm equals the absolute risk reduction that Bob showed in benefit?
Phil, do you want to take that?
Well, I can try. The only study that I can cite off the top of my head that tries to address that is the paper that Matt Budoff mentioned in his talk, that Mark Pletcher from UCSF is the first author. And what Mark did in that paper was he modeled the decision about statin therapy based on risk assessment with Framingham risk score, and adding on top of that routine coronary calcium measurement. And what he was trying to get at was, I think, Dr. Baumer's question of where's it cost effective to use a statin, and where's it cost effective to add coronary calcium to that decision. And as I remember the paper, it works out, first of all, it matters what you say is a statin side effect. Okay, so an obvious statin side effect is if you have to pay for it. But the other statin side effects are, I think, to some extent debated. Like, how often does it really happen that people get myositis from a statin, as opposed to just aches and pains that people have from other things? But in that paper, roughly at about the 5% estimated risk using the Framingham risk score, below 5%, the decision to use statin was a negative decision. It was avoid statin, which pretty much I think all the guidelines recommend, and above 20% routinely give statin. And in the intermediate, and that's where some of these recommendations come from, between 5% and 20% estimated risk, depending on how serious you think the statin side effects are, and how costly statins are, and how costly a coronary calcium scan is, your decisions are going to be different. And, you know, without kind of showing you the data, that's the best that I can remember.
Okay, and Nathan, did you want to follow up?
Yeah, very briefly, because I think pretty much what Phil has said is correct. In the when the 2013 guidelines came up, we did an analysis and showed that there was what we call net clinical benefit, right? Where the number needed to treat is balanced with the number needed to harm at a ASCVD risk level of 7.5%. Okay, so above that, you're going to have more benefit than you will harm. And then how that relates to coronary calcium scoring, I think was nicely illustrated by Matt's 2018 10-year follow-up paper from MESA that shows that regardless of ethnicity, if your calcium score is 100 or greater, you're at least 10% 10-year risk. So these individuals would clearly benefit from statin therapy according to that guideline.
Thank you. Dr. DeMaria.
Yeah, so a couple of points. I was interested to see that the debate focused on the risk of events. I'm a workaday doc. I'm not an epidemiologist, and I find the CAC score most useful when it's 0. And I would say, Bob, you know, when the task force looks at it and says there's no evidence that it adds to risk screening, you know, for those of us out in the world, a score of 0, it seems to me, is pretty useful in a lot of ways. The other thing, Bob, when you show the benefit of statins, those are pools of patients that have not been risk stratified for CAC. Now, it's conceivable that if you redid those studies and risk stratified the patients for CAC, that in fact the statins would be much more valuable. I mean, it's clear that treating people who don't have disease is not going to help very much. So I just throw those out as comments.
Well, Tony, first of all, it's good to see you, and thanks for the question. And I think that the best way for me to answer this is just to bounce it to Matt, I was curious about this issue of people who have zero CAC, but you assume that they're at very low risk for bad outcomes. But there may be is there a subset of people that are zero or close to zero CAC, but actually have high ASCVD scores? And does the zero CAC actually provide protection for them despite, I mean, for example, you wouldn't want to say to someone, right? I don't think you'd want to say to someone, your CAC score is zero, so you might as well, feel free smoking.
Well, I would always say, we don't want to, I always tell people, a negative HIV test means that you don't have it now. It doesn't mean that you're impervious to the disease. So I would use the same logic with a calcium score of 0, that if you have a score of 0 now, you don't have the disease, but it doesn't mean you can't get heart disease. So you don't want to live poorly, smoke, start, you can go out and celebrate maybe and have a nice meal, but I wouldn't, to denigrate your diet significantly or gain weight, thinking that you're immune to athero. But every population-based study, and Nathan can talk to this as well, every population-based study shows your calcium score of 0, regardless of ASCVD risk, you're low risk. So even if you take a high-risk person, like a patient with diabetes, who has a score of 0, their risk, their short-term risk is low. I think you're going to see more and more advocates of and societies and guidelines that are going to push people to say you should even risk stratify higher risk people, because if you get a score of 0, as Dr. DeMaria said, it's very helpful. You can down titrate or not escalate therapy, and therapies are expensive. And if you don't need it, not forever, but for 5 years, that's a wonderful endpoint.
Thanks. Many of the panel have their hands up, and I promise I will call upon all of you. I just have to, I wonder from your comment, Matt, how you define a nice meal. Because what you implied was, oh, you have a calcium score of 0, then you go out and have a nice meal, meaning...
What that you're buying, David, that's a nice meal. When you buy it for me, that's a nice meal. No, okay. You celebrate, you don't go crazy.
Noelle?
Just to sort of expand, and this is not to anyone in particular, but if you look at lifetime risk, it is 40%. So flip a coin, and this is what people die of and what they're maimed by in the last 10, 15, 20 years of life. And there was a Northwestern modeling recently in circulation, Phil, your name is not on it, that demonstrated that lifetime risk would be more cost effective for statin therapy compared to basically screening. I mean, they tried everything else and lifetime risk was the best. So here's the out of the box question. Now that we've got a probably ultimately inexpensive shot, because inclisiran is similar technologically to the Pfizer and the Moderna that are $20 a shot, will we ever be in the situation, to coin Matt's phrase, to absolutely prevent disease, not wait for the calcium score to be positive, but actually prevent disease? Nobody wants to take it.
Well, I think that's a question for David Maron. If that's a preventive cardiology question.
Oh, and this is
what would we do? Just put in TAVRs all day long?
Oh, because they die.
Be out of business.
They die of something else. Yeah, and the shot might protect against cancer. You're right.
I'll take a shot at that, and that is that I'm a huge proponent of CAC, but you can't really identify people until they're generally over age 40. But polygenic risk score may be a way to identify those who might indeed benefit from what Jennifer Robinson calls a vaccine.
Preventive.
Like inclisiran, with aggressive risk factor control, specifically in the example, using the example you used with inclisiran. That might be a way, instead of just treating everybody, or as Phil said earlier, putting statins in the water, to be a little more targeted in that kind of approach.
Yeah.
And I might also add that there are currently some CRISPR technologies that are under development, even to essentially knock out PCSK9. So this is really going to be a vaccine. I think in Quizeron, some of us like to think of it as a vaccine, although the sponsors do not. It is still very expensive. It's a couple $1,000s a shot. So
didn't have the U.S. government paying for it.
yeah.
So I think we have, if people can stay with it 24 minutes, and I think this is a great discussion. So I'm going to take the moderator's prerogative and ask a question of the panel about intensity of statin therapy in people who are young and have a very low calcium score. How do you treat, or how should we treat, young patients who have just a calcium score of 5, but they're 41 years old, say? Should we treat, do we have an LDL target? Do we have an intensity of statin therapy? Not to mention other risk factors that have to do with lifestyle and blood pressure control, et cetera.
Well, I'd love to hear what Dr. Harrell or Dr. Sky have to say about that, because their entire population is pretty much young people.
Mm-hmm.
And I just asked, why did you get the CAC on them in the first place?
Because of a very strong family history, or maybe, you know, they just referred to you, but and someone else got it, or they got it on their own.
They get it on their own. Yeah.
So
yeah, and obviously people get CT scans for lots of reasons. So sometimes you incidentally find it on a CT scan that were done for other reasons. I'll say that in our population, if someone has a positive calcium score and they're young, I think of them as they're greater than 75th or even 90th percentile for their sort of age-adjusted, gender-adjusted, ethnicity-adjusted risk. And they're on a curve that, at least from my standpoint, as I look to you manage them in the military health system, maybe short-term or long-term, or handing them off to the VA or handing them off to the civilian sector, that I really need to look at bending the curve for their lifetime risk. So generally, I'll treat them with a high-intensity statin if they can tolerate it. I, like Dr. Budoff talked about, I generally reserve aspirin therapy for those patients who have a calcium score of 100 or greater, just because I think their risk is better reflective of the risk-benefit relationship. But I treat them with high-intensity statin therapy if they have a positive calcium score and they're young.
And I agree with what Dr. Harrell said. I think that the approach I take is I also measure an Lp(a), and then I'm a huge fan of Dr. William Harris's article from JACC, maybe 2014, on an LDL cholesterol of 30 to 50 to stabilize plaque, if not reverse it. So I pay more attention to the combined effect of statin therapy or whatever additional therapy they need with their lifestyle and other modifications for exercise. And I aim for more of a cholesterol goal than what level of statin they're on.
Thank you. Dr. Yu, you're on mute.
Yes, thank you. Great discussion. I would like to ask, in a subpopulation of patients with diabetes, are there additional nuances that the CAC score can inform us? So current guidelines have us view patient with diabetes as having coronary artery disease equivalent, and the standard is to put them on statins universally. In practice, we have seen some challenges for patients for a variety of reasons, and in particular for patients that are on the younger side, say 45, with an LDL that's less than 70. We have had clinicians concerns about, are these patients really need to be on statins if they're already based on LDL at below 70? So is there any research to inform us whether CAC scoring in this population would be beneficial, or this is like standard for the general population, they do a CAC score and based on the score determined to 0, then they're excused, or they're high, then you put them on high intensity. So curious for any insights on the diabetic population with regards of the utility of CAC scoring. Thank you.
Maybe I could briefly comment. I don't know if I got your entire question, but you know, I've done some work in this area, and clearly, you know, in the MACE diabetes population, for example, if the CAC score is 100 or higher, they're basically a risk equivalent for CHD. So that certainly supports the use of high intensity statin in those individuals. I think people with lower levels and consistent with the guidelines, you know, remember they do recommend use of at least moderate intensity statin. We don't down or we don't delay the use of statin in those with a 0 score. So remember what the guidelines say, and this relates to the earlier question, right? If you have a strong family history, or you have diabetes, heavy cigarette smoking, for example, the 0 score should not be used to withhold statin therapy. And conversely, you know, if your score is, if your risk is 20% greater, and this was shown, you know, initially in Khurram Nasir's 2015 paper, that you are still in the statin benefit range, even if your calcium score is 0. But in people with diabetes, you know, you remember guidelines do recommend at least a moderate intensity statin. I do believe, though, that a higher CAC or even the presence of CAC can help motivate better adherence, because we know many people with diabetes are not even on a statin at all. We see this among University of California system-wide data, for example. So there's a big clinical inertia problem, and calcium scanning can help motivate better adherence to statins and other preventive therapies, as you know, data that we have published, Matt and others, and the PAC study has published, showing that a picture is worth 1,000 words.
Thank you. Dr. Harrell.
Yeah, thank you. I wanted to kind of get back to the question of the sort of power of 0 calcium score. And I wanted to sort of pose it to Dr. Kaplan as far as we look at the evidence for calcium scores for risk stratification. You know, I think if you look at the data for the power of 0 for calcium, that it greatly discriminates risk. And you look at the Walter Reed data where we looked at it relative to statin use and saw, you know, no benefits for statin in that calcium score 0 group, with about 9,000 subjects that sort of met that group total. You know, if we're to say, well, we need randomized controlled trial evidence, I mean, how would we ever ethically design a randomized controlled trial to see if patients with calcium score 0 might benefit from statin therapy? And I think that it's hard pressed that any of us could design a trial that might be useful in that subgroup of patients. So I think for that purpose, for screening to exclude risk, it would be useful to sort of comment on. Let me know what your thoughts are and views on that.
Well, first of all, it's a really good question. And, you know, it does raise an interesting ethical question. And I guess, as I understand it, the ethical question is, you've got people who are at very low risk. And so putting them on statins may increase their risk of other things slightly. And is it ethical to do that trial? One of the things I found interesting, you know, Phil had this slide, and I have a different slide from the N. Haynes data. But what's interesting is that, you know, a substantial portion of all people on statins are at low risk. I mean, defined as at least 20, you know, ASVD, CVD scores less than 20%. So actually, it's something like 70%. It was a surprisingly high number. And so that there certainly are a lot of people out there who are on statins whose risk for bad outcomes is relatively low. So I'm not entirely convinced that it's unethical to do this study, but it'd be interesting to hear what other people have to say.
Does anyone want to comment?
Not
I thought it was
study a large number of people for a very long time.
Yeah, I'm not sure that it would be unethical, but I would say one of the reasons we don't have a coronary calcium clinical trial is that the number of people that you would need to treat, even in the intermediate risk group, is huge. So a number of us proposed a trial about 10 years ago. It required about 30,000 patients whose estimated risk was between 7.5% and 10%. And the reason we chose that limited window was because we were trying to avoid going above 10% for the reason that Nathan Wong said earlier. Above about 10%, the net benefit is considered to be already present for statin therapy, and the guidelines are recommending the use of statin above that level. And below that level, as you add more and more low-risk people to the trial, you need to add more and more people to the trial to show any benefit at all. So we tried to pick this, let's say, ideal range for the trial, and it was still 30,000 people. And when you added that all up, it was about $80 million. We had trouble getting that funded in NIH. I don't think it's unethical. I just think it's almost impossible to just pull it off.
And Phil, I'm just curious, how do you feel about, so, there are a lot of people now that seem to be arguing that for people with LDL cholesterol below 100, or just pick some number like, say, 80, then there should be intervention to get them down below some other number, 70, 60, and so forth. And you see a lot of this in the advertisements for the very expensive PCSK9 inhibitors and so forth. As far as I can tell, there really is no clear evidence from trials that there is a benefit in terms of outcomes. Certainly, you can get people's cholesterol lower. And you bring up this interesting point. To do that trial is going to be ungodly expensive. What do you do about that?
What happens, I think, Bob, and to answer that question, is you have a panel at the ACC, and there's like 15 people or something on the panel, and 7 say it's a good idea and 8 say it's a bad idea. None of us really has any really solid evidence to answer that question. There are these extrapolations that would suggest that lower is better. And there are the biological arguments. Biological argument is that when you're born, your LDL level is like 50, or maybe even lower than that. And so presumably that's the ideal.
We lost
for brain
Phil.
development and things like that. So there are a lot of different opinions on that topic, but I don't think there's a lot of solid data on that topic.
Okay. Noel, did you have a quick comment?
Oh, I was just going to say, I also thought it would be ethical. Remember, hormone replacement trials were considered unethical until NHLBI did it, and look at, how important that turned out to be.
Thank you. And so I'm going to try to manage the time we have remaining efficiently. I do see 2 raised hands. Dr. Vora, is your hand up on purpose?
Yeah, thanks. And thanks for the good discussion. So I was just sort of reflecting on the parallels in stroke and with our intracranial atherosclerosis and carotid disease. and how, you know, for so long we have not used those parameters as screening or predictive of stroke risk in the same way. I feel like there's just a lot of parallels here, and I don't know if we're always 10 years behind cardiology or if we're now kind of converging, but I think that right now when we see, you know, scan for any reason, MRA, CTA, and we see plaque in the intracranial arteries or in the carotids, we're just doing medical therapy. And that really comes down to, you know, blood pressure, smoking, and statins with an LDL goal. Even there debated 100 versus 70, like really falling more in the primary prevention category. And I'm curious, you know, we've talked a lot about statin use, but then of course there's aspirin and the risks with aspirin. And this is actually hotly debated in our world, is whether these patients should really be put on aspirin. So I'm just wondering from the group where you fall on that, and for those that are trialists in this area, you know, do you think there's adequate brain imaging or cerebrovascular imaging being included? And will that tell a different story? Because I know the carotids part hasn't exactly panned out yet in MESA. So curious to hear people's thoughts, because I think there are a lot of parallels. And sometimes when we make decisions about the CAC score, you know, there's still risks up here. So that was my point to Dr. Yu.
Anyone want to take that?
I'm asking a bunch of cardiologists about the brain. That's my problem here.
Yeah, well, I guess I could take a stab at it. Yeah. So, you know, yeah, I think there are a lot of parallels here. And we know that more recent guidelines with actually aspirin have really kind of backpedaled a bit. And, you know, as far as their use in primary prevention, and even what's interesting is that from the large diabetes trial, you know, the ASCEND trial, there was basically a balance. The benefit was pretty much outweighed by the risk, even in higher risk primary prevention diabetes. So it really, I think, largely boils down to an individual decision, you know, and considering all the potential risks. I did want to add briefly to Bill's comments about the lower to better issue. And I totally agree. There are no randomized trials, say, comparing, say, you know, less than 30 versus, you know, less than 50. But we, of course, do have the post hoc analysis from the PCSK9 trials that do seem to show continued risk reduction, further risk reduction down to an LDL level of around 20 with no where there's no further benefit achieved. And we even see this with the intravascular ultrasound study that was done involving evolocumab, which is called actually Glagov, that we continue to get further regression of atherosclerosis down to an LDL of around 20. So, you know, the lower the LDL hypotheses, at least in secondary prevention, because all these studies were done in people with ASCVD, remember, remains pretty strong, and the Europeans, in fact, have lower targets of less than 55, and also the Lipid Association of India that I'm involved with has stipulated an even lower target of less than 30 LDL for extreme risk individuals. So it is something, certainly, though, that deserves further investigation.
Thank you.
So, Nurali, I just have a brief comment on this, and that is that, you know, the aspirin example is why I think looking at all-cause mortality is important. And, you know, if you go back, actually, you know, I don't know if you remember the Physicians' Health Study. I know you were very young when it was published. It was published in the 1980s, but, you know, about 22,000 physicians were randomly assigned to 325 milligrams of aspirin or placebo and then followed prospectively. And the trial was ended early because there were more deaths from myocardial infarction in the placebo group than the aspirin group. And the study was important because it really did change all kinds of things for quite a long period of time. But then people started realizing that, well, maybe that it's complicated, that you might actually have an increased number of strokes, for example. And that actually was there in the Physicians' Health Study data. And that if you actually looked at deaths just from cardiovascular diseases in the original study, just in the New England Journal of Medicine publication, and add them up, there, in terms of all-cause mortality, even way back in the 1980s when it was published, there were exactly the same number of physicians that died in the placebo group as in the intervention group. And so, again, I think it's an example of why it's important to look at sort of this underlying all-cause mortality as opposed to the little pieces. And we still get that. People will say, if you look at aspirin, then there might be a decrease in MI, but an increase in stroke, but also an increase in colorectal bleeding and so forth. And it just becomes too complicated to try to do all the adding and subtracting.
Yeah, I mean, I think it's a fair point. It's kind of like we're going back to the same question that you're asking for CAC. Are you treating CAC when the score reaches a certain threshold as primary or secondary prevention in the asymptomatic patient, which I think was asked earlier. And for the brain, we continue to treat it as primary prevention until someone has a symptom. And it may be because we do see, we are worried about that risk of bleeding. We always were, and now even more so in the brain with aspirin, for example. But I guess I'm hearing the group sometimes saying, right, that if the CAC score is above a certain number, now you're starting to treat it as secondary prevention. And I'm just wondering if, when we do see that discrepancy between intracranial athero and cerebral and coronary athero, is there going to be some threshold we find in the brain that also brings us to that? And you guys have these great cohorts that really kind of wonder if we can get more intracranial data as well to answer these questions for us.
We are down to the last 2 minutes. I know that Dr. Balmer, you raised your hand. Do you have a very quick comment to make?
Yeah, just a quick comment is we focused a little bit on coronary calcium for primary prevention, i.e. screening, primary prevention. But we've talked about data related to 3 groups. One is secondary prevention, where statins do really well and PCSK9s do well. And our target is really in secondary prevention. I try to get down to 70 LDL in those individuals. Primary prevention, we're a little easier. We're talking moderate in cases, and I try to get LDLs under 100 in that population. And as the data shows that Dr. Kaplan showed, it's harder to show benefit in primary prevention because the curve is flatter. The last group is going to be primordial prevention, where it's going to be extremely difficult to show benefit because the benefits are really small and you have to have a large group of individuals. But possibly in the future, if we get to very easy things like single shot once a year or once every 5 years or something, there might be a benefit in that population to prevent the progression of coronary calcium to higher levels, where it then enters into primary prevention and then later secondary prevention. So we've got to keep our groups of populations different, and we're going to have different recommendations in each. But the 2 speakers today, I think, did a very good job of contrasting those groups in the primary prevention. And I certainly want to thank them for the efforts they did, as well as our other speakers.
Thank you. We're at 5 o'clock. And I want to thank our RCI for organizing this. I thought it was crazy to have such a long session. I thought it worked out really well. And I want to thank the speakers and our great panel. I thought it was a very engaging, great discussion. So thanks very much. Hattie, I have to hand it to you, and I hand it over to you to say whatever you're going to say.
What an amazing team effort. Just beautiful. It's kind of incredible, the momentum that has built since we had our first public meeting in 2008. And what a wonderful thing that now we are no longer bound by our region. So I've been able to introduce our cardiologists from San Diego to Los Angeles to Sacramento to Silicon Valley, et cetera. It's a wonderful moment, frankly, to hear this discussion today. I think everyone learned a lot from each other and will want to collaborate more together. We will have our next major session, only 2 hours, just a brief little meeting on Monday, April 11th, with our first co-chair who graduated from our San Diego group to then become the Chief Medical Officer of the American Medical Group Association, and then going on the President and CEO of AMGA. Dr. Jerry Penso worked really closely with Dr. DeMaria, Dr. Scott Flynn, Liz Helms, and myself in getting our first Right Care University best practices off the ground. And so please plan to join us for that as well. But meanwhile, I have to say the most compelling slides for me were the military slides that showed, and you can take down the slides now, thank you. Travis Harrell's slides on the observational data for large numbers in the military, showing not only the power of statins for those with high coronary calcium scores, as opposed to no power of statins for those with 0 scores, but also that stroke data that you showed. And I think we've lost, no, Nurali's still with us, and I would love Nurali and Dr. Harrell to just collaborate afterwards on some data exchange. But it looked to me in that data that the stroke risk for a high calcium score over a period of a decade or more is actually higher than the risk from a heart event. But that could be a whole separate session. And Travis, do you want to talk about that? You're muted.
Oh yeah, sure. Yeah, no, I don't know that this has been borne out on all the calcium data trials, but certainly in the Walter Reed sort of registry, the risk of stroke, if you, the curves are very similar to the MI curves with each level of calcium. You know, there is, it's not as great of a risk discriminator as far as the calcium score is 0. The curve was up a little bit higher than the MI curve, which probably goes to reflect that, you know, we're looking at the calcium in the coronaries and not in the cerebrovasculature, as well as that there's a lot of different mechanisms for stroke. They're not all atheroembolic. But yeah, the calcium score was very predictive of that stroke risk. Very, very similar curves as the MI curves. And I still, like many people have mentioned, that calcium score is 0 in that population over 40. And especially as people get older, you know, if you're in your 70s and you have a calcium score of 0, you've probably won the game. You know what I mean? Just because so many years have passed and you've had so many opportunities to start calcifying any plaque that you would have in your coronaries, and that if you're in your 70s and you haven't had calcification yet, you're at a very low risk relative to your population, you know, age, gender match population. So
I think we've all had a wonderful day together. Many of us could talk for hours further, but people need to get back to their patients. And I just want to thank you all for bringing your amazing passion for improving patient outcomes and your brilliance and melding minds for the greater good. So bless you all. Thank you. And we'll see you in a couple of weeks.
Bye.